Sorry for the technical glitches. A very good morning, ma'am. I acknowledge presence of you, ma'am. Shuchi Jain, ma'am. A very good morning. I'm really sorry for the technical problems which everybody must have faced for logging in. But then finally we are here at 9:30. The day has come. Every year we are waiting for this day. The team OBGY NKP Salve Institute of Medical Sciences in association with NOGS is organizing this event since many years, PG conference. This is exclusively meant for the postgraduate students which are benefited by this grand academic feast, faculty all over the India, and they are financing the skills these postgraduates have. They can improve their presentations, table vivas and case presentations in their upcoming exams. So this is actually a big effort taken by the entire team along with all the national faculty, which is actually benefiting every student, and not just the student, but also the faculties all over, because it's a continuous medical education. It's a continuous learning process, which everybody we are in. So I welcome you all, ma'am, and myself, Dr. Rita Bang, Assistant Professor at NKP OBGY, rapporteur for today. Myself, Dr. Amrita Singh, Assistant Professor here at LMH. Will be today's MOCs, and will be in very short while we'll be starting up. Just give us 2 minutes. Our one of our eminent judges have come. We are just waiting for another eminent judge. And I also request our first team members, first presenter Charmi and Priyanka Dapkekar to join soon. We'll wait for a few minutes for Joshi ma'am to join. Let's start the presentation. Ma'am, we shall start the presentation.
Yeah, you can start. Sulba ma'am has joined.
Unable to reach to her. I'm waiting for her only, but then she's not there and she is not able to again. We are not able to reach her. Shall we start, ma'am?
Yeah, it's fine with me. You can start.
Yes, ma'am.
You can start.
Okay, ma'am.
Yeah.
I welcome you, ma'am, Dr. Shuchi Jain, ma'am. She is the professor of OBGY department and gynecology at Mahatma Gandhi Institute of Medical Sciences, Sevagram. We all know her. She's been affiliated to n number of bodies, national and international bodies like NQOCN. She's a member of NMG for Lakshya, investigator for ICMR projects on hypertension, abortions, and rubella. She is also a part of WHO project and a part of Government of India in emergency obstetric care, maternal death surveillance response, and maternal near miss review. She is also handling the PCH bundle project by Harvard University, US. She's been awarded with late Dr. Praveen Mehta Fellowship in Endoscopy and also the best paper presented in Mehsana, Baroda. She has n number of national and international indexed publications and also contributed in WHO manual for cervical cancer screening, contributed to the book of family medicine. She has special interest in high-risk obstetrics and oncology. I welcome you, ma'am, on this team.
Thank you.
Today for the group A, we have 6 teams, mixture of paper and poster from the 6 people from LMC and from GMC, IGMC. The first paper will be by Charmi Vashi. She is a student of our institute. She'll be presenting, the title will be ferric carboxymaltose versus iron sucrose in treating postpartum anemia, parenteral iron therapy. So over to you, Charmi. Reminder for everyone for the time of the webinar. A reminder for the presenters, the timing of the presentation will be 6 + 2 minutes, and the first reminder bell will be given at 4 minutes. So 6 minutes for presentation and 2 minutes for discussion.
Can I start? Good morning, everyone. I, Dr. Charmi Avdesh Vashi, under the guidance of Dr. Nikita Vijay from NKP SIMS and LMH Nagpur, present to you this paper titled Ferric carboxymaltose versus iron sucrose in treating postpartum anemia, a better parental iron therapy. Introduction. WHO has defined postpartum anemia as hemoglobin less than 10 gram% during the postpartum period. The prevalence is 4 to 27%. About 20% of the maternal deaths worldwide are attributed to anemia, whereas in India, 80% of it is attributed to anemia. The major causes are iron deficiency, anemia, and in combination with acute blood losses at delivery. Oral iron therapy is presently the treatment of choice for iron deficiency anemia, but it has certain disadvantages. Moreover, HB starts rising from 3rd week, but replenishment of iron stores may take up to 3 months. Parenteral iron helps in restoring iron stores faster than the oral iron. Multiple doses and prolonged infusion time is required for IV iron sucrose, whereas ferric carboxymaltose is a novel non-dextran agent having very low immunogenic potential and therefore very low risk of anaphylactic reaction. Because of all these properties, it is possible to administer large doses of this injection in a single rapid session without requirement of test dose. and thus we can overcome the limitations of the existing intravenous IV agents. It has been FDA approved for clinical use in India and is found to be safe to administer. Currently, there is very limited evidence from the secondary care centers for the use of FCM for moderate or severe anemia, and moreover, there are very few studies which have been conducted in India. Therefore, to further strengthen this data, this study is carried out to evaluate the efficacy and safety of FCM over iron sucrose in treating postpartum anemia. The aim and objective of the study was to evaluate the efficacy and safety of FCM injection in improving hemoglobin level and serum ferritin in postpartum anemia, and to compare it with iron sucrose in treating postpartum anemia. My study was a randomized controlled trial done in our hospital setting, including the postpartum women having hemoglobin less than 10 gram%. It was done for a duration of 6 months from May 21 to December 2021. The following formula was used for sample size estimation, and the total sample size was 60, 30 being in each group, A being those who got FCM injection and B getting iron sucrose. The sampling technique was convenient sampling technique. Patients with history of parental iron intolerance or allergy, having thalassemia or sickle cell disease, previous history of blood transfusion, or history of chronic systemic illnesses or bleeding disorders, or those suffering from renal or hepatic impairment were not included in my studies. Method and data collection. After obtaining permission from the Institutional Ethics Committee and after written informed consent, women with hemoglobin less than 10 gram% willingly to participate in the study were included. A detailed clinical history was taken. Apart from this, ANC investigations were noted at the time of admission. Repeat hemoglobin was done 24 hours post-delivery, and women having postpartum anemia were counseled for either of the above mentioned parental iron therapy. Complete hemogram, serum ferritin, and peripheral blood smear for cell morphology was done before and after 4 weeks of administration. Vitals were noted before, immediate after, and 30 minutes post-administration in both the groups. Adverse reactions were noted, and if required, they were treated. After all the prerequisites were obtained, the women were divided randomly into two groups. The group A receiving IV FCM, either 500 milligram in 100 ml NS and a maximum dose of 1000 milligram in 250 cc NS, infused over 15 minutes after a dose calculation. Not more than 1000 milligram was given in a week. The dose used was the following mentioned, which is by Ganonzi formula, that is 2.4 into HB deficit into body weight plus iron storage deposit, which is taken as 500. Group B, the one who received IV iron sucrose, 300 milligram in 250 cc NS on alternate days till the required dose is completed, and to a maximum of 600 milligram given per week. The following dose was used to calculate the total dose infusion required for the iron sucrose. The results of my studies are as followed. The two groups are comparable in terms of age, mean weight, parity, socioeconomic status, incidence of antenatal anemia, incidence of postpartum hemorrhage, and mode of delivery, and no statistical significance was found. Whereas comparing both the groups in terms of mean hemoglobin pre and post transfusion and mean ferritin pre and post transfusion, the study was found to be highly significant, whereas change in the mean hemoglobin and serum ferritin after blood transfusion was also found to be highly significant. Whereas we can see in this table, the change in hemoglobin was 2.81 gram per DL in comparison to group B, where it was only 1.6, and rise in the serum ferritin was by 163 nanogram per DL, whereas in group B it was 114. Comparing the adverse reaction, group A had lesser adverse reaction compared to group B, and the study was found to be significant in this aspect. Discussion. My aim was to compare the efficacy and safety of FCM with iron sucrose in postpartum anemia. My study conducted said that both of them are effective in improving HB and serum ferritin, but the mean rise in both the values were more in group A compared to group B. Ferric carboxymaltose this is because FCM is a non-dextran iron-rich complex which consists of a ferric hydroxy core stabilized by a carbohydrate shell. Because of this, it permits guarded delivery of the iron to the cells, and with a negligible risk of large amount of ionic iron being released in the serum. And moreover, it has low immunogenic potential, and therefore it is predisposed to less risk of anaphylactic reaction. And because of all this, we can administer a large dose of FCM, that is a maximum of 1000 milligram in a week compared to IV iron, which is only 600 milligram. Conclusion is postpartum anemia is mostly left untreated, as for many women
Sorry for the technical glitches. Actually, there is little network issue. Well presented, Charmi. FCM versus iron sucrose in postnatal period, which is a better parenteral iron therapy. A very well presented paper by Charmi Vashi. Ma'am, over to you, ma'am, for the discussion.
Yeah, Charmi, it was certainly an excellent presentation regarding ferrous carboxy maltose. Can you tell me one drawback of giving ferrous FCM? Like you have told us about the advantages. What is one disadvantage? You can tell me.
Ma'am, actually the cost is more compared to the IV iron, and therefore many patients are reluctant in taking FCM. But if well counseled regarding the benefits and lesser hospital stay, it will be really helpful in treating the postpartum anemia with better increase in serum ferritin at an early stage.
Yeah, that's right. And what are your comments about role of FCM in antenatal period? Can we give it?
Ma'am, actually, there are few studies which have been conducted to implement the use of FCM in antenatal period, but as of now, it is not FDA approved for its use in antenatal period.
Yeah, that's right. And what were your findings in relation to PPH? Like, why did you mention PPH in this? Because
ma'am, it is also one of the cause which can result into postpartum anemia. So it was just taken as a demographic variable to compare the rise in the HB in both the groups.
Yeah, so basically we are not treating acute blood loss with iron therapy. So yeah, but it's a good observation which you have made. So I think it was a good presentation. Yeah, we can move on. Subla ma'am is there. She would like to ask something.
Yes, ma'am. Yes, ma'am.
Yeah.
Ma'am, Shulva ma'am will be joining us in a while. We have invited our another guest, Somalwar madam. We are waiting for her also to join it. She's an associate professor in our institute. She's also an American Heart Association's also an DLSO instructor. She's been an PPIUCD trainer, and she's also a very enthusiastic academician and helping our students in growing their academic skills. So moving on to the next presenter, we have Priyanka Dapkekar. Her title of the paper poster is MTP Act, a must know for every gynecologist. Over to you, Priyanka. Welcome, Sarita ma'am. Madam, I also wanted to ask whether at your place, antenatally, have we started FCM, or the thing is we give only in postnatal, ma'am?
You want to ask me? Yeah, like
yes, ma'am. Yes, ma'am.
Yeah, the problem is it is not FDA approved. So that is why till it is not FDA approved, we cannot actually give it. So we have
Okay.
not tried it, yeah, but in postpartum we are giving it and we are getting good results. So patients who are affording, they are getting it and we are giving it.
So even your experiences are really very good in the postpartum
Yeah, I
period.
think only the cost factor is the issue. Otherwise, the experience is good. Like the rise in hemoglobin is much better.
Have you encountered any reactions, madam, with FCM at your place?
No, not as now. In iron sucrose, we had a few anaphylactic reactions, but not for FCM.
Okay. Okay, ma'am, our next, thank you, ma'am, for your input. Our next presenter is ready with a presentation poster. Priyanka, over to you.
Priyanka, you're not audible. Have you started? I'm not able to hear you. No. Not yet. We are not able to hear you.
Am I audible, ma'am?
Yeah, now you're audible.
No, Priyanka, you're not audible.
Ma'am, am I audible?
Yes, now we can hear you.
Okay.
But it will be better if you can be a bit more louder.
Yeah, ma'am. Sorry, ma'am, for the interruption. First of all, we will discuss why it is important to know what is the MTP Act in India, because there is 8% of maternal mortalities because of unsafe abortions. It's according to the census of 2003, and it's shown in the pie chart given in the chart. Then because that's why every gynecologist needs to be updated about the MTP law regularly. And next we will see the chronology of MTP acts in India that has been passed since 1860. First, it was the Indian Penal Code in 1860. Then further came the MTP Act in 1971. Next came the MTP Amendment Act in 2002. Next came MTP rules in 2003. Then comprehensive abortion care guidelines by Government of India in 2010. Then came the CEC guidelines second edition in 2018. And last one, the recent one is the MTP Amendment Act in the 2021, which is the latest one. Now, first is the Indian Penal Code 1860. According to it, any induced abortion is a crime, and the person that the provider should be punished a 3-year imprisonment for the crime, and the woman who is undergoing the abortion should should get punishment for the 7 years of imprisonment. Then next one is the MTP Act 9 that came into force in 1971, which legalized the induced abortion in India. According to it, who can do the MTP is any registered medical practitioner, and where can it be done in the government hospitals or recognized MTP centers. It can be done at up to the week of 20, up to 20 weeks of gestation, and for that up to 12 weeks of gestation, opinion of one RMP is required, and for the 12 to 20 weeks of gestation, opinion of 2 RMPs is required. Next, what are the indications for MTP under MTP Act 1971? If there is a risk to the life of the pregnant woman, or there is grave injury to the mental or physical health of the patient, that is, if the pregnancy is caused by the rape, or there is failure of contraception in a married couple. It's highlighted that it was for the married couple only. Then if there are fetal malformations that are not compatible with the life or would result in serious handicap. And in MTP Act 1971, consent of the women, only women is legal, and it can be accepted. And only in case of minors or lunatic patients, the consent of the guardian is required. Next came the MTP Amendment Act in 2002, where it's for the better implementation and access to the MTP services for the women. And here the term lunatic was replaced by the mentally ill, and it advised stricter penalty for the unsafe abortion. It also introduced the district level committee to recognize the MTP centers. Next came the MTP rules in 2003, where detailed instructions for the implementation of the act came into play, and it introduced the medical method of abortion various, and that the drugs which can be prescribed by the RMP at the outdoor clinics. Here, the experience of the RMP is required in the degree or diploma in obstetrics and gynecology he should have, or there should be a 6-month residency in the obstetrics and gynecology. He should have 1 year working at experience of 1 year working at the recognized MTP center, or the person should have assisted 25 MTPs or done 5, and he can do MTPs till the week of 12 weeks of gestation. Next came the Comprehensive Abortion Care Guideline, Government of India, in 2010, followed by 2018, where MMA at outdoor clinic up to 7 weeks of medical method of abortions at outdoor clinic up to 7 weeks of gestation with established linkage to the MTP centers was legalized, and but the person it should have display the person should display the linkage, and medical method of abortion up to 9 weeks of gestation at the recognized MTP center. It also introduced the non-oral misoprostol form for the 7 to 9 weeks of gestation medical terminations of pregnancy. Next came the MTP. Recent one is the MTP Amendment Act in the 2021, where the opinion of one RMP, it has got many benefits for the patient, as the gestational age has been raised to the 24 weeks in case of in certain situations, and opinion of one RMP up to 20 weeks of gestation is sufficient, and the opinion of 2 RMPs is required from 20 to 20 weeks of gestation, where it is done in case of if the patient has been a victim of rape and or survivor of the rape, and if the patient is minor or difficulty handicapped, differently abled, sorry, then if the gestational age more than 24 weeks, and if there is a substantial risk to the substantial fetal abnormalities, then it should be approved by the medical board, which consists of 4 members, where 1 gynecologist, 1 radiologist, 1 pediatrician, and other member of the committee should be there. Then next came the breach. If there is breach of confidentiality, then punishment has been 1 year imprisonment and or fine, or both. And in case of failure of contraception for any woman and her partner, or in case of unmarried woman, this MTP is legal now, which has been in case of married couples according to MTP Act 1971. The MTP Acts MTP Act has been for the benefit of the patient, who to become more approachable and to provide health benefits to the patients without getting unsafe abortions and getting into the medical complications. So this was the presentation, and
very nice presentation, Priyanka, and a very good and hot topic in these days because of the amendments. I think every practitioner in the city, outside the city, everybody is so confused regarding these new rules and regulations, and everybody is scared to put into that. So very good topic you have raised. I would request Shuchi ma'am to give expert comments on this. And there's one request from the presenter. Actually, if you keep your videos on, the presenter and the examiner and the rest of the people who have joined this platform would really feel connected, even if we are on a virtual platform. Over to you, ma'am.
Yeah, Priyanka, well presented, and certainly a hot topic right now in Vidha, because all of us know because of a particular case. right? So I was not very clear from your presentation as to which terminations are allowed between 20 to 24 weeks according to the new amendment. So can you elaborate on that?
Yes, ma'am.
Because
According to
not
new
all
amendment,
terminations are allowed between 20 to
no, ma'am.
24 weeks. So
No, ma'am.
what all are allowed here?
Only the patients who are my victims of rape, survivals of the rape, then the patients who are physically disabled, differently disabled, then in case of incest case, where many times the because family members, in case of family relations, uh, the cases of sexual assault can happen and patient may suffer from that. They allowed for the abortion, medical termination of the pregnancy.
No, so if she is a lady above 18 years and she wants medical termination, but she is unmarried, so and she is beyond 20 weeks, can she go in for termination?
Beyond 20 weeks of
But she is more than 18 years, but she is unmarried.
because it's for the special categories which doesn't include the unmarried patient. For unmarried patient, only till the 20 weeks of gestation, the patient can undergo legally. That's the difference, because in
Yeah, so
MTP Act
that is one of the
1971, it
flaws,
was only for the married couples. Yes,
right? So what other flaws do
yes.
you think, or what problems can arise because of this amendment act which has been introduced in 2021?
Many of the time, ma'am, patient who are unmarried, that's the one case, and uh, if there is more than 24 weeks of gestation, the patient is approved for the termination of the pregnancy, but there is need for the approval by the medical board. It's
Yeah, that is true.
more
But see, it has been done for the betterment. But do you think there could be some issues which can aggravate because of this amendment? I mean, if you are increasing the limit to 24 weeks, what all can happen? There are always some drawbacks or some cons to whatever you do, right? Though we welcome
yes,
it,
ma'am.
but what could be the major disadvantage which can happen because of this act, which has now been extended to 24?
Sorry, ma'am. I will.
Okay, and why do you think we have increased it to 24 from 20? What was the need? Why it was increased from 20 to 24? What was the major
Ma'am,
reason behind it? Yeah.
many of the times patient first visit was at 20 weeks of gestation, and without any anomaly scans, and the patient, if the baby had anomalies and the weeks of gestations are more than 20 weeks, then it was not legalized, and patient could have suffered from the patient has to accept the pregnancy and
Yeah,
give
and
it.
with the advent of fetal echo, quite a lot of cardiac anomalies were being detected late, right? Beyond 20 weeks. And this act was proposed 50 years back. So a lot of changes have taken place in the medical science in the last 50 years. So there was a need to increase it to 24. But then somewhere female feticide may increase because of this, not legally, but illegally, because of this increase to 24 weeks, right? So
Yes,
that
ma'am.
concern is there for all practitioners and the government that female feticide should not increase because of relaxing this law. Okay.
Yes. Okay.
Yeah. Thank you.
One
Thank
question,
you, ma'am.
Priyanka.
Now I invite Savita, ma'am. Yeah.
It was very nice presentation, Priyanka. I want to ask one question for injury to mental health, whether there is any need that the psychiatrist should give a certificate that yes, she is having a problem or what?
No, ma'am. In case of patients where there is a pregnancy because of failure of contraception, the patient doesn't need a certificate by the psychiatrist, because the patient is under mental stress, which uh, in return in which will result in the depression and other things of the other psychiatric problems with the patient. So it's
Okay.
not that recommended.
Okay. Okay. Very well done. Thank you.
Thank you, ma'am. Thank you for that. This is, in fact, the revolutionary change which I find in this MTP thing is the woman has been given all the power. Now she can decide independently whether she wants to terminate or not. She need not need any approval from her spouse or from her co-partner. So thank you, Priyanka. Moving on to our next presentation by Dr. Achala Singh. Achala, her title of the paper is A Comparative Study of Early and Late Onset Preeclampsia. Achala?
Hello, yes, ma'am.
Yes. Could you please share your screen?
Yes, ma'am.
And please switch on your video too. Yeah. Yeah, please start.
Is it visible, ma'am?
Yeah, it's very well visible.
Good morning, everyone, respected teachers. I'm Dr. Achala Singh from IGGMC Nagpur. The topic for my today's presentation is a comparative study of early and late onset preeclampsia.
To interrupt you, Achala, could you please switch on your video also?
Yes, ma'am.
Yeah, please start.
Yes, ma'am. First, we start with the background. Hypertensive disorders of pregnancy are an important cause of maternal and perinatal morbidity and mortality. It is the second most common cause of maternal deaths worldwide. Incidence of preeclampsia is 3 to 5%. It is divided on two types based on gestational age. Early onset preeclampsia from gestational age of 20 weeks till 33 weeks 6 days. Late onset preeclampsia.
Can you play it in slideshow?
Sorry, ma'am.
Can you play it in slideshow?
Yes, ma'am.
Yeah, that's better.
And late onset preeclampsia, it starts from 34 weeks onwards. EOP is a placental disease and LOP is a maternal disease. It is characterized by, according to ACOG 2019 guidelines, new onset of hypertension after 20 weeks of gestation and significant proteinuria of 2 plus or 0.3 gram in 24-hour urine test, or it may be new onset of hypertension and significant end organ dysfunction with or without the presence of proteinuria after 20 weeks of gestation. As we can see in the image, the end organ damage consists of thrombocytopenia less than 1 lakh, impaired liver enzymes, that is twice the normal value, new development of renal disease, that is creatinine more than 1.1, pulmonary edema, new onset cerebral or visual symptoms. The objective of our study was to study the various risk factors in both early and late onset preeclampsia, to study the maternal and perinatal outcome in early and late onset preeclampsia. The various risk factors are as follows, and it is divided into two categories, high risk factors and moderate risk factors. The high risk factors consist of women with previous history of preeclampsia, multifetal gestation, chronic high blood pressure, kidney disease, diabetes mellitus, autoimmune conditions such as APLA. The moderate risk factors are nulliparity, pregnancy interval more than 10 years, BMI more than 30, age more than or equal to 35 years, in vitro fertilization, black race, family history of preeclampsia, and lower in socioeconomic group. The study setup was in a tertiary center in central India. It was a prospective observational study and was run for a period of 2 years from October 2019 till September 2021. It included 182 cases of preeclampsia, and they were divided as 91 cases in each group of early and late onset preeclampsia. The data was collected during their ANC registration, regular ANC visits during labor and postpartum period, detailed history including name, age, socioeconomic status, detailed obstetric history along with personal and family history. Detailed general and systemic examination was done along with laboratory investigations routine and specific for preeclampsia. Ultrasonography with Doppler and DISIS was done. The results were as the distribution of subjects according to age are as follows, and the maximum number of patients were in the age group of 25 to 29 years, that is 49.45 in EOP and 37.36 in LOP, and the p-value was not statistically significant. The other risk factors were as the lower socioeconomic group class, the EOP were 38.46% and 39.56% in LOP. The primary gravida was more found in LOP, that is 64.84%, and it was statistically significant. Higher BMI was associated with EOP, and this was also statistically significant. Family history of hypertension was more in EOP as compared to LOP, and this was significant, and history of preeclampsia in previous pregnancy was more in EOP than LOP, but this was not statistically significant. The severity of the disease was more in early onset preeclampsia, that is 61.54% as compared to the 32.97% in LOP, and this was also statistically significant. Then the greater number of preterm deliveries were in EOP as compared to late onset preeclampsia, that is 71.43% as compared to 17.58% in LOP, and this was also statistically significant. There were greater number of cesarean sections in both the groups, that is 62.64% in early onset and 37.36% in late onset, but this was statistically not significant. There were various maternal complications like eclampsia, postpartum hemorrhage, abruptio placenta, HELP syndrome, thrombocytopenia, oligohydramnios, ICU admissions, maternal deaths, and these were all more in early onset preeclampsia as compared to late onset preeclampsia. The Doppler findings, the abnormal Doppler findings were more in early onset as compared to late onset, that is 49.45% in early onset and 19.78% in late onset, and this was also statistically significant. There were more number of stillbirths in early onset, 18.68 as compared to 5.49% in late onset, and this was also statistically significant. There were more number of low birth weight babies, that is less than 2.5 kg in early onset as compared to the late. The other fetal complications like Apgar score less than 7 at 5 minutes, NICU admissions and perinatal deaths, all these were more in early onset as compared to the late, and the p-value for all of these complications were statistically significant. So we come with the conclusion, the maximum number of patients were in the age group of 25 to 29 years, that is 43.41%. The mean age group was 26 years. Primary gravida were more in late onset preeclampsia group as compared to early onset. Higher BMI was associated more with early onset preeclampsia group than late onset preeclampsia. Family history of hypertension was seen more in early onset as compared to late, and there were greater number of preterm deliveries and stillbirth in EOP. There were greater number of low birth weight babies in EOP. The maternal and fetal complications were also more in early onset as compared to the late onset. The implications of our study are the classification of preeclampsia into early onset and late onset has both etiological and prognostic importance. There is a need for regular antenatal checkups so that gestational hypertension can be detected at an early stage before it progresses to preeclampsia, and timely intervention can be made to avoid an unfavorable outcome. Early detection, monitoring, and timely intervention results in good maternal and perinatal in both forms of preeclampsia. Early onset preeclampsia requires close monitoring and vigilance, as it is a condition we cannot prevent but reduce its complications. And thank you for your patient hearing.
Thank you, Achla. Now I invite judges, Ruchi ma'am and Sarita ma'am, for the questions.
Thank you, Dr. Achla. It was certainly a very good presentation and a topic of a lot of relevance, because preeclampsia is still a major maternal killer and a reason of major morbidities. Now, there was one finding which you stressed upon is that primary gravidas had more chances of late onset preeclampsia. Can you elaborate on this, and why do you think you got that finding?
Ma'am, nulliparity, primary gravida is obviously associated more with it is associated with preeclampsia in both the forms, but in our study, it was more as I found more association with late onset preeclampsia. It is due to the exposure of the immunologic response of the patient to the paternal antigens. It is obviously a more risk factor for preeclampsia, as the mother gets exposed to the paternal antigens for the first time. If there is an abortion or a previous delivery, the risk of preeclampsia decreases.
Okay. You talk something about abnormal Doppler findings. Now, suppose you have a patient who's had a preeclampsia in an earlier pregnancy, okay, and now she has come to you. So, right from the first trimester, what all Doppler studies will you do to find out her risk of developing preeclampsia in this pregnancy?
Yes, ma'am. Firstly, we'll start with the uterine artery Doppler. We'll see the pulsatility index in the first trimester. There is also called a combined test. The various tests are available for the prediction of preeclampsia. In the combined test, we use the uterine artery PI, mean arterial pressure.
In your study, what all Doppler studies did you do in patients of preeclampsia?
Yes, ma'am. I did uterine artery Doppler, I did umbilical artery Doppler and MCA, and we did not rely only on the absolute values. We also calculated the cerebroplacental ratio and see its relation on the chart.
What is the significance level for cerebroplacental? What is the cutoff where you'll consider it significant? What should be the ratio?
One.
So ideally it should be more than 1. If it is less than 1, that means the fetus is getting compromised. So Malva ma'am, any questions?
Dr. Achula, it was a very nice presentation. I want to ask one thing. You have categorized into high risk factors and no risk factors.
Yes,
so whether a low dose aspirin was given if you find that there were risk factors in your study?
Yes, ma'am. Low dose aspirin was started right from the 12 weeks and it was continued till 36 weeks. 150 milligram.
How many risk factors you consider in a moderate and high risk?
Ma'am, in high risk, if there is presence of only one risk factor, and in the moderate, presence of more than or equal to 2 risk factors, according to the NICE guidelines.
Okay. And any exclusion criteria in your study? You did not mention, I think. Exclusion criteria.
Yes, ma'am. Exclusion criteria were those patients who had the other comorbidities like diabetes, chronic kidney disease, chronic hypertension. I also excluded them.
And what regarding multifetal pregnancy?
Ma'am, only singleton pregnancies were included.
Okay. Okay. And I want to ask, what do you mean by early onset IUGR and late onset? No, there is another, like early onset preeclampsia, the definition differs. No? What do you mean by early onset IUGR?
Yes, ma'am. It is also less than 34 weeks and more than 34 weeks.
It is less than 32 early onset, less than 32 weeks and more than, okay, early and late onset. Okay. Okay, thank you.
Thank you.
Thank you, judges. Out of the scoreboard, I would like to ask one question to Achula, which will not be in your scoreboard, just for the audiences also. What are the conclusions of ASPRI trial? First, have you heard of ASPRI trial?
Hello. Yes, ma'am. Yes, ma'am. It is the aspirin trial. The percentage of reduction of the preeclampsia is 10% more to the patients whom we give the aspirin, and it also delays the onset of preeclampsia from 24 to 36 weeks. Like 20 weeks, there is a lag of the development of preeclampsia symptoms.
Almost like your studies, they had 2 groups, early onset and late onset. So we'll go through it. And to Suchi ma'am, I would like to ask, ma'am, at your place, how much dose aspirin you give for prevention of preeclampsia?
Yeah, we are following the 75 milligram, but nowadays there is evidence for 150 milligram also. So in really high risk patients, we can give 150 milligram also. But at present, because of, we are giving 75.
Yeah.
Right.
Yeah. Thank you, ma'am. Now next, we invite our next speaker. Anushri Shetty. We invite Anushri Shetty for a poster presentation on POCSO Act, relevance to gynecologists.
Good morning, dear judges and respected seniors. I am Dr. Anushri Shetty, junior resident from NKP SIMS Nagpur, and my guide is Dr. Anjali Kotalkar. My poster for today is POCSO Act and its relevance to a gynecologist. The government of India brought this special law, POCSO, Protection of Child Against Sexual Offences Act 2012, which came into force on 14th of November 2012. This act has two main goals. One is to protect the child from sexual offenses, and two is to make a judicial law which is child friendly by incorporating child friendly ways of investigations and further procedures. This is a very sensitive topic, and it would be very helpful if we as gynecologists know a little better about this topic. Let us understand this act a little better with a few case-based scenarios. Case 1. A 14-year-old female came with her parents with USG reports suggestive of single live intrauterine pregnancy of 10 weeks plus 6 days. History of penetrative sexual assault was there 3 months back by a relative. The patient was shunted to 4 different hospitals with no police information. How did we proceed? Consent of the child was taken, examination was done, simultaneously the local police was informed, MLC was done, decision of MTP was taken, the products were preserved and given to the police for forensic examination. Later, when the decision of discharge of the patient was taken, the CMO of the hospital informed the local police for the further proceedings in this case. The highlight of this case is for us as doctors to know about this act, and the failure to report such cases will lead to 6 months of imprisonment or fine or both. Case 2. Can a woman lodge a complaint for an offense done prior? Does it come under POCSO Act? Example, a 25-year-old female comes to lodge a complaint for a penetrative sexual assault 10 years back. Yes, she can do it. There is no time frame to lodge a complaint under POCSO Act. Case 3, a 15-year-old orphan child comes with a case of sexual assault by a stranger. How will you proceed? Being a male doctor, we will inform the local police and we will refer the patient to a female doctor. Under POCSO Act, a female child has to be examined by a female doctor. And when the child is being examined, a parent or a guardian has to be present. Or if there is no parent or a guardian, then the head of the institution appoints a woman under whose presence the examination is done. Case 4. What type of sexual offense is it, and why is it so important for us doctors to know this? Example, a female 16-year-old comes on her own to you as she was touched by her male teacher at school in her breast region and private parts. This is an aggravated sexual assault, aggravated because it was done by a person she trusted upon. It is very important for us doctors to know this, as our case report written by us will decide the punishment of the offender. There are a few definitions which we need to know under POCSO Act. 1. Child, a person below 18 years of age. It's a gender biased law. Sexual assault touching with sexual intent. Aggravated sexual assault on a mentally ill child or by a person in authority. Example, your police officer or a person you trust, by your teacher, doctor, leading to harm or death, pregnancy, a child. Sexual harassment, any sound, gesture, exhibition of body parts with sexual intent. Or 6, pornography related. It is very important to know these definitions because the punishment with various different sexual acts differs. It's maximum for aggravated penetrative sexual assault and the least for sexual harassment, which is up to 3 years. Case 5, a 18-year-old female is brought by her relatives to your institution with case of aggravated penetrative sexual assault, and the patient looks much younger and you are in doubt about her age and the patient has no identity proof with her. Will you go for medical age estimation? Yes, only in cases of dilemma, and if the patient has no identity proof, you will go for medical age estimation. And if the patient doesn't give you consent for examination, you have to write down a refusal, not do the examination, and then inform the local police. By this case, we understand that it is very important to take down the consent of the patient before doing any investigation, treatment, or anything. And if the patient doesn't allow, then you have to write down a refusal and inform it to the police. Case 6, a 15-year-old brought by her relatives with chief complaints of bleeding PV since 1 hour. Pulse is feeble, BP 90/50, with history of sexual assault 2 months back by a neighbor, and USG suggestive of single live intrauterine pregnancy of 8 weeks. Patient was in no condition to give you consent. Will you treat her medical condition? Yes, in cases of emergency, we must treat the medical condition without having any consent. My take-home message from my poster is that there is an urgent need to educate your healthcare professionals, police officials about the POCSO Act. And it is there in our UG and PG teaching curriculum, but it should be emphasized upon, as all of us should know this act. Thank you.
Very well presented, Anushri. And the topic which you have taken is actually again another hot topic, because this act is also not very well known by everybody of us. So we really need to get acquainted with this law. And again, along with this, there is one more thing which is associated, which is child line. So I request the judges, and before actually going on to the point, I acknowledge presence of Shama Kedar ma'am. I welcome you, ma'am. Very good morning. And I'm really sorry, ma'am. Actually, we are running because of some technical glitches. We are running just 20 minutes late, ma'am. So do bear with us, ma'am. Yeah, over to you, Shuchi Jain, ma'am.
Anushri, certainly a very excellent presentation. But can a 15-year-old and a 16-year-old give a consent? How valid is that consent?
Ma'am, if she's in a mentally normal state, she can give a consent. We have to take her consent. If it is a child below 12 years of age, then you have to take a consent of a guardian or a parent.
So between 12 to 18, you mean to say her consent is valid?
Yes, ma'am, it's valid.
I don't know if somebody can throw more light on it, because I was under the impression that less than 18 years, the consent is not valid.
Ma'am, below 12 years, it's
Okay.
not. From 12 to 18 years, it's valid.
Okay. Suppose she is after 18 years and she's come to you for a MTP, then does she come under POCSO Act?
Then she won't come under POCSO.
No, but the conception or the act has occurred before 18 years, because now she's coming for delivery, right?
Yes, ma'am, then she will come under. That's what my case number 3 highlighted, that there is no time limit in which she can come and lodge a complaint for an act which was done below 18 years old.
No, what I mean to say is she is beyond 18. Now she's come to you for delivery. Okay. She's 9 months pregnant.
Okay, ma'am.
But that act has occurred when she was less than 18 years.
Yes, ma'am. Then it will come
yeah,
under.
so
Yes,
it's not that she's coming after 10 years or 5 years.
yes.
She's coming in the same pregnancy during that course. But even if she's beyond 18 years and she's come for delivery, but that act has occurred when she was less than 18 years.
Yes, ma'am.
So that comes under POCSO Act.
Yes.
Yeah, a very excellent presentation, and there are quite a few people who are not aware of it. So I think you've done a good job by presenting this. So
Thank
over
you,
to
ma'am.
Somalva ma'am. Yeah.
Anushri, it was
Somalva
very
ma'am, we
nice
would like you
presentation.
to keep your video on.
Yes, ma'am.
It was very nice presentation with many concepts cleared by, I think, everyone. Okay.
Thank you,
And what is the difference between assent and consent? And there is terminology, assent. Okay. What is child helpline number? Can you tell all the who are attending? Helpline number. Okay. It is 1098. I am. Anyone is differing on this? I know it is 1098.
Yes, ma'am, it's 1098.
Yes, it's fine.
No, and 1098.
Yes.
So that should be, you should be able to tell, no? Like,
Yes, ma'am.
yeah.
One important message related to this 1098, actually this POCSO Act people, they had come to our place and we had conducted a CME on it. So they had actually said that once any patient who comes to you and you are in a doubt of her age and the patient is not carrying the age proof, wherever you are, be it in a private practice or be it in your institutional practice, and if you are in doubt about that case, you have to call 1098 and let them know about such and such scenario. So you are safe from your side. Even if you don't inform police from your side, 1098 people, they will inform the police that such and such doctor had called, that this patient was with her in her practice, in her cabin, and she has reported to this situation. So we are safe from our side if she falls in POCSO Act. Yes, thank you so much, Sumarva ma'am.
Thank you, ma'am.
Moving on to the next presenter.
We have Manjusha Yadav. She'll be presenting a poster on bilateral uterine artery ligation with cervicotomy, a rare conservative surgical management for cervical ectopic pregnancy. Manjusha, are you ready? Please share your screen.
There's one request for the poster presenters. Actually, if you little zoom it out, then all of us will be able to better read it. There is an option in your poster present, when you present your share screen, there is an option of zoom. So if you press the zoom button, you can share it in a better full vision view so that everybody can read your poster well. Till she is logging in, I would also like to add one more thing, which that POCSO Act CME had given us a message that there is one website called kara.in. So earlier where the adoption rules used to be sent, now the adoption rules have got centralized. So whenever we are facing any patient who is unmarried and coming for delivery and they don't want to accept the child, they don't want to accept the baby. So instead of, contacting the orphanage, it is better we contact these people, childline number, and then they will register that baby also to kara.in website, and the new couples which are in need of adopting children, they also register at kara.in. This was one new actually extra information which we got in that CME, so I just thought of throwing light on it. Yes, Manjusha, are you ready? Yeah, keep your video on.
Yeah. Hello.
Yes, you're audible and it is readable. You can proceed.
Good morning, ma'am. I'm Manjusha Yadav, and I'm presenting a case report on bilateral uterine artery ligation with cervicotomy, which is a rare conservative management for cervical ectopic pregnancy, under the guidance of Dr. Varsha Kose and Dr. Nikita Vijay. Case history is that Mrs. X, who is a 26-year-old female, was referred from a private clinic, Gravida 3 Para 1 Living 1 A1, with previous scar with gestational age 7 + 6 weeks. And she has complained of spotting PV when she came to private hospital. There she was given tablet mesoprostol 3 tablets, and after that she started bleeding, soaking 2 to 3 pads per day. And after that she was referred to our hospital, where we examined her. She was clinically stable. Per abdomen was soft, non-tender. And on PS, os was pinpoint and circulus. On PV examination, os was closed and cervix was ballooned up. Investigations were done. HB was 12.1, platelet was 2.09, and we did her serial beta HCG. Initially, her beta HCG was more than 60,000. After 48 hours, it became 13,490. We repeated her beta HCG and it became 10,000 in next 48 hours. So serial beta HCG showed decreasing trend, and after 1 month, it was less than 2. On USG finding, it shows a single live gestational sac in the cervical canal. Cardiac activity was present and it shows cervical ectopic of 6 + 5 weeks. So we did her bilateral uterine artery ligation with cervicotomy. Intraoperatively, uterus was normal size and shape. Echo texture with bilateral ovaries were normal and adnexa was normal. So bilateral uterine artery ligation was done. Cervix was ballooned up with maximum bulge in the posterior cervical wall. So small vertical incision was given over the posterior cervical canal. Products of conception were removed using ovum forceps. Digital exploration was done using little finger, and internal os was closed. Gentle curettage was done using blunt curette. There was no active bleeding, so incision was closed with Vicryl 20 and the procedure was uneventful. As you can see in the picture, if it is visible, the uterus is normal size and there was an incision given. We are trying to remove the products of conception using ovum forceps in the picture. So, ma'am, the aim of presenting this case is that in case of cervical ectopic, especially in cases of previous scar where there is no vaginal delivery, os remains circular and pinpoint and tubular. So, cervical dilatation may be difficult. So, in such cases, cervical tomy with bilateral uterine artery ligation can be performed. There are various other methods of management, like clinically stable patient can be managed medically by giving IM methotrexate 50 milligrams per meter square, and single dose shows 80 to 90% response. If fetal cardiac activity is present, we can give local injection of methotrexate along with KCL injection, and multiple methotrexate with folinic acid can be helpful. If medical management fails, then vaginal ligation of cervical branch of uterine artery, followed by suction evacuation and curettage can be done. Histoscopic resection of products of conception after uterine artery embolization can be performed. For controlling of bleeding, Foley's tamponade can be used. If uncontrolled bleeding is present, then uterine artery embolization and lastly hysterectomy may be performed. I would like to show a small video of the procedure to explain it even more, to elaborate the procedure. Ma'am, as you can see here, you can clearly see the uterus size is normal and there is a small vertical incision is given over the cervix, and using the little finger, we are trying to remove the products of conception and ovum forceps.
पेपर लेते क्या?
So, ma'am, this is a very rare literature has been found. Only one case has been performed previously. So, thank you. This was my case.
Thank you, Manjushri. Ma'am, I would like to invite for the questions.
Manjusha, well presented, but there are a few concerns which I'm having. One is that you're saying that she had cervical ectopic.
Yes, ma'am.
And then patient took MTP pills at private clinics. So how is that so that with a report of cervical ectopic, he was given MTP pills?
Ma'am, actually, she first went to private clinic and they did her USG there, which shows it was the query ectopic, cervical ectopic query missed abortion. So that they gave tablet mesoprost to her. After that, she started bleeding, and then she was referred in our hospital where we did USG. And in this hospital, it shows clearly that it was a cervical ectopic on USG.
Okay, so there was some mismanagement at their side.
Yes.
Secondly, like since she has got only one live issue and you have done her posterior cervicotomy, so how do you think you're going to manage her subsequent pregnancy? Because she would surely like to go in for another baby. So what advice and what plan do you have for her subsequent pregnancy?
Yes, ma'am. As we have done her cervicotomy, we would like to we will counsel the patient that if she wants to conceive further, she would have to opt for section that will be a safer option for her, as vaginal delivery might be problematic.
Yeah, but her future obstetric career is at risk now. So probably, why don't you go for some other conservative method before going in for a surgical procedure? That could have been the last resort.
Yeah.
Put the medical methods tried. I mean, other mechanical and medical methods tried.
Ma'am, again, that was the reason that os was completely closed and pinpoint. So if we would have tried dilatation and curettage, that would have been difficult. And in cervical ectopic, there is 1/3 chances that patient may lead to hemorrhage, and we would have to perform the uterine artery embolization and bilateral uterine artery ligation. So we opted for this option.
Okay. Shama ma'am, Somalwar ma'am, your comments.
Yeah, please, Somal ma'am.
What are the criteria for diagnosis of cervical ectopic?
Ma'am, there is Rubin's criteria, which is post after hysterectomy, and there is MacLean criteria. So in Rubin's criteria, there is a cervical gland is seen opposite the site of placental attachment. Then there is internal os is closed, and it is ectopic pregnancy is found below the insertion of uterine artery. And in MacLean criteria, there is painless vaginal bleeding is seen. Then there is internal os is closed, and uterine, I mean the size of the fundus and the size of the cervix is equal, and the cervix is seen ballooned up.
Okay. And ultrasound diagnosis?
On ultrasound, we will see there is no intrauterine pregnancy, and there is a sliding probe test will be negative. I mean, if we want to differentiate it from missed abortion, in that case, we'll see the floating gestational sac if it is a missed abortion. In cervical ectopic, it won't. It will be negative. And
missed abortion, or you are confusing between, suppose sometimes the products have come into the cervical canal, no? है ना? Cervical ballooning.
yes, ma'am, after abortion. Yes.
Missed abortion, no?
Yes, ma'am.
The products, the entire products of the uterine cavity has
Conception has come down to the cervix.
from the cervical ectopic, no? Not
Yes,
missed
ma'am.
abortion, what you were saying.
Yes, ma'am.
Okay. It was a nice presentation, Manjusha.
Thank you, ma'am.
Thank you, Manjusha, and thank you, judges. Now I invite Vishal. He'll be presenting a poster on vesico-uterine fistula during cesarean section in a case of previous cesarean section, an obstetrician's nightmare. Vishal, are you ready? Vishal, you can upload your poster. Can you share? Because we cannot see it.
Yes, ma'am. One second.
Start sharing, Vishal.
Yes.
Yeah. Yeah, go ahead.
Good morning, dear seniors and officers. My topic for the poster today is vesico-uterine fistula during cesarean section in a case of previous cesarean section and obstetrician's nightmare. Mrs. X referred from private hospital post-operatively. LSCS was done 6 hours back in view of fetal distress in second stage of labor. Patient was referred with an IV line and catheter in situ. On examination, general condition was and systemic examination was within normal limits. Urinary catheter and urobag was having frank blood. On per speculum examination, there was gush of urine seen in the speculum. There was no rent visible. On per vaginal examination, cervix was high up, vagina appeared intact. Urosurgeon opinion was taken and a CT cystography was done. Defect of 1.8 centimeter was noted in the posterior wall of the urinary bladder, communicating with the anterior wall of the lower uterine segment for an anterior posterior extension of 3.2 centimeter with a positive contrast noted passing from the bladder to the endometrial cavity, suggestive of vesico-uterine fistula. Decision for laparotomy was taken. Counseling was done to the relatives about injury to the bladder, fistula formation, and need to repair the fistula. After opening, it was seen that the bladder was stitched with the upper uterine segment. These stitches were removed. I would like to show in a video demonstration how it looked intraoperatively. As you can see, here you can see the anterior and posterior wall of the bladder. With the Babcocks, the posterior wall of the bladder is held. The bladder is retracted, and here you can see the anterior and the upper and lower edge of the lower uterine segment. This was the intraoperative picture. The rent was seen at the anterior bladder wall. Posterior wall of the bladder was irregularly damaged. Lower border of the lower uterine segment was injured, thinned out, and slipped down. Ureteric catheterization was done using infant feeding tube, its other end removed out through the urethra by side of the urethral Foley's catheter. The anterior and posterior wall of the bladder was opened and both the ureters were checked. As we could see the urinary flow, that was confirmed that the ureters are not injured. And another urethral Foley's catheter was passed. Its aim was to keep the bladder repaired during the surgery. Direct passage of urine was allowed to the exterior. Now, the injured dome of the urinary bladder and its posterior wall was repaired using Vicryl 2.0. Suprapubic cystotomy was done. Then the torn edge of the lower uterine segment was identified and stitched vertically, and the lower border of the lower uterine segment was created. The upper edge and the lower edge of the lower uterine segment was then sutured together. Hemostasis was achieved, and an omentum was brought between the two, and there were stitches and covered with stitches. 2 to 3 stitches were taken. Post-operatively, patient was vitally stable. Ureteric drains expelled out spontaneously on days 3 and 6. The urine output was adequate. Patient had a wound gape on day 10. Resuturing was done after 10 days of regular dressing and injectable antibiotics. First, the Foley's catheter was removed on day 15. Clamping was done, and it was seen that the patient could perceive, patient felt like passing urine and could get the sensations. And then, and clamping was done every 4 hourly, so that patient has the urge of passing urine. There was no discharge from vagina. Suprapubic catheter was removed on day 17, and patient was discharged, and patient went home with a healthy scar. Aims of presenting this poster are history and previous records are very important in a case of previous lower segment cesarean section. Facility preparedness should be ensured to handle such events. Otherwise, patients should be referred to a higher center. In a case of previous cesarean section, trial of labor should be given very cautiously, and all guidelines of TOLAC should be strictly followed. Thank you.
Thank you, Vishal. Now I invite judges, Ruchi ma'am and Sumala ma'am, for the questions.
It's certainly an interesting case, and we do encounter such cases once a while. So this was a case of previous LACS in which trial was being given. Is that so?
Yes, ma'am. There was a previous lower segment. This was the second section, and patient was from their reports, we understood that patient was in labor, and when she was 8 centimeters dilated, there was fetal distress. So patient was shifted for emergency section in second stage at 8 centimeters. So there was a previous scar and second stage of labor. So the risks were more in this patient too.
Fine. So what are the various type of fistulas you are aware of in obstetrics? And can you describe a simple test to differentiate between them? Yeah.
There is a vesico-uterine fistula. Then you have a vesico-vaginal fistula, ureterovaginal fistula, and urethrovaginal fistula. You use a methylene 3 swab test to differentiate between them. You keep 3 swabs at the level of the
Okay, so you know that, right? What are your views on clamping? Should the catheter be clamped in a patient who has undergone a repair for a fistula?
Ma'am,
At the time of removal.
Yes, once the bladder is allowed to heal, like the tissue which is sutured is allowed to heal, we check for sensations, because then then as the patient is getting sensations, we clamp. Yeah, once we give it time, say 2 weeks, for the bladder tissue which is repaired to heal, and then clamping helps in patient understanding the urge for urine passage, for passing urine.
Yeah, but you clamp for 4 hours, which is a very long time, you know. So maybe we can redo and rethink on it. Yeah.
I also differ with Vishal. Clamping for clamping. It will give us space and the sutures will give way. Yeah. So I don't think urologists are also advocating clamping nowadays.
Okay.
And another thing, Vishal, I wanted to ask, what went wrong in this case? Initially.
Vishal, can you switch on your video? It is connected.
Actually, the video is playing the other way around, so my face is not.
Okay, no problem.
In this case, when the patient was shifted, maybe the lower uterine segment was very thinned out, and the incision was taken on the bladder, on the dome of the bladder, and hence, while suturing, they couldn't differentiate between the lower uterine, the bladder and the uterus, and that's why while suturing also, the lower segment, the lower border of the lower uterine segment had gone down, so that's why it couldn't be sutured with the upper uterine segment.
So the incision, as she was in a second stage of labor, the incision should have taken
a little
higher on the uterus. Yeah.
Yes.
So injury has occurred during that time only, and then the suturing it was not identified at that time, and hence she came with all these things. No?
Yes.
Proper mobilization of bladder and taking incision high up on the uterus. That is very important in second stage of labor.
And also early diagnosis of this and immediate intervention gives better results post-operative.
Diagnosis. First step is prevention. First step is wide mobilization of bladder down. Second thing is secondary prevention is identification during the surgery and doing the procedure in the same setting.
Yes,
suturing should have been done in the
same. The event should have been identified then.
So vigilant and diagnosis is very, very important. Okay.
Thank you.
Thank you.
Thank you, judges. Thank you, Suchi ma'am. Suchi ma'am, personally, I would like to thank you. This is not a platform to speak on a personal thing, but I started my journey of senior residency under your able guidance. So I still remember those were my kindergarten days. So in the NSR, accepting our invitation as a judge, and you really added spice to our first group of students at the session. I also thank Savita ma'am for the last minute approach and the approval and judging the session. Thank you, judges, for the thing. And next on, we move to our next session.
Thank you, Amrita and Rita. We certainly enjoyed these presentations, and it was nice to see you again.
Yeah.
And we look forward to such interactions more often.
Definitely, definitely.
Thank you. Yeah.
Thank
Bye,
you.
both of you. Sure.
See you.
Yeah.
For the next session, we have our two set of judges, Kauthalkar ma'am and Shama Kedar ma'am. I invite Kauthalkar ma'am and Shama Kedar ma'am. Kauthalkar ma'am, She's a professor at our LMH. Madam has been, you can say, academic head of our institute. She's been teaching the students, taking special interest in their all the classes. Madam, apart from that, she has a special interest in emergency care in obstetric and gynec. She's been a provider and instructor for ACLS, also BLSO, and an additional qualification recently she has attended, and that is a post-graduation in diploma in medical law and ethics, are very important. So any one of us, if requiring any help for any legal issues, we can anytime connect our ma'am. She's been a teacher, postgraduate teacher since more than 30 years, many researches and publications. Her special hobby, which I would like to mention about, is that bird watching and photography, which we have been witnessing every day in and out with our occasions and our platform. Welcome, ma'am.
I welcome Shama Kedar.
Thank you.
Who doesn't know Shama ma'am? Ma'am is an associate professor and unit head at Obstetric and Gynec Department, Indira Gandhi Government Medical College, Nagpur. She is an MOGS representative of NOGS 21-22 duration. She has a postgraduate teaching experience of more than 20 years, and she has developed a unique workshop of pelvic anatomy and evidence-based cesarean section. She has many awards to feather her cap, many national and international papers presented in conferences, more than 35 papers published in national and international index journals, and she has won first prize for paper presentation and gold medal in AICC RCOG 2017. She has been receiver of Khandwala Best Paper Award in 2016 and recipient of gold medal of NOGS in 2016. She has a very special interest in high-risk pregnancy, HIV, and pelvic anatomy. I welcome you, ma'am. Over to you, ma'am. Shama ma'am and Anjali
Thank you.
ma'am.
Thank you. Now, can we start, Anju?
Yes,
Yes,
ma'am,
yes.
definitely.
Sure.
And
Okay.
now moving on to our next session, I invite Dr. Rashmi Sakharwade, who will be presenting a paper on misoprostol versus suction evacuation in management of patients with incomplete abortion. Rashmi? Yes. Unmute yourself and start sharing your slide. Yes, we can see it. Can you make it slideshow?
Yes, ma'am.
Yes, that's better.
Good morning, respected chairperson and my dear colleagues. I'm going to present paper on misoprostol versus suction evacuation in management of patient with incomplete abortion under guidance of Dr. Sulabha Joshi. As we all know, incomplete abortion, when the part of a product of a conception are written in the uterine cavity, it's associated with the complications like hemorrhage, infection, anemia, sepsis, and therefore it's a major public health concern. And that's why it needs to be managed urgently. The gold standard technique for the treatment of incomplete abortion is a suction evacuation. But since a suction evacuation is a surgical procedure and it's associated with the anesthesia associated risk, surgery associated risk. Therefore, from a few years, we are using misoprostol as it is a prostaglandin analog and it's very cheap, stable drug with a long shelf life and alternative option for the management of incomplete abortion because it reduces the hospitalization as well as reduce the anesthesia related risk with the success rate of which vary from 40% to 99%. With keeping this in mind, we conducting a study to evaluate the efficacy of misoprostol with respect to suction evacuation in management of patients with incomplete abortion. Here, in study group where oral misoprostol is given and 30 included in a control group where suction evacuation done. We use here sampling techniques, convenient sampling technique. Women with incomplete abortion who visited to LMH Lata Mangeshkar Hospital as in coming to obstetric ward as well as in OPD with exclusion and including criteria which include inclusion criteria, intrauterine pregnancy with the gestational age of less than 12 weeks, USG suggestive of written product of conception, and the patient who is willing to come for follow-up after 7 days, willing to undergo surgical evacuation if heavy bleeding seen during medical management or if the medical management failed. Exclusion criteria, which the women with the severe anemia who bleeds more, having bleeding disorder, infection, some profuse bleeding, some of the contraindications like glaucoma, sickle cell disease, severe hepatic disease, heart disease, severe bronchial asthma, history of current serious systemic or medical surgical condition. We took a detailed menstrual history, OBS history, gravity, parity, gestational age, past medical history, if any surgical history, family history are noted, and all the findings are noted in a case report form. In a group A, where tablet misoprostol 600 microgram were given orally, and in a group B, which is where the women who want to do a suction evacuation are considered. In a group A, single dose of tablet misoprostol 600 microgram given orally, time of intake of misoprostol noted, close monitoring of the vital sign and bleeding was done, patient allowed to go home after 4 hours and asked to observe for bleeding and the passage of product of conception. Asked to report after 7 days and assess for the success and completion of procedure by ultrasonography. Timing of passage of the product of conception were noted. If found incomplete, suction evacuation was done and hemoglobin estimation was done on the day 7th or before sending home. In group B, suction evacuation done primarily by following hospital protocol, and the patient was discharged after 12 hours of abortion. They called for follow-up after 7 days and hemoglobin estimation was done. In both the groups, we asked for any complication if they having foul smelling or bleeding discharge or any result after observation. Group A and Group B compare for age, socioeconomic station, and gravida. Results are as follow. In a Group A, where 30 women are taken, 28 are successfully done with medical method, and therefore the percentage, as we can see in the Group A, 93% is a success rate and Group B is 100%. Now induction abortion interval is mostly it is within 24 hours, and the complications seen in Group A are more as compared to Group B, and hemoglobin difference of less than 1 is seen in both the groups. From the above study, studies, we can discuss as ACOG guidelines come in study in 2009, which introduces the medical method for incomplete abortion. We have studies for the misoprostol and suction evacuation. From the above study, Chikabu B et al. Study where the misoprostol, the success rate was 45%. To vary this 100% success rate, and from the above study, we can conclude that the misoprostol is safe alternative to surgical management and is free of complications related to anesthesia and surgery and need for hospitalization. Patient with incomplete abortion need counseling regarding management, and option should be given as an option for a medical management. These are the slides showing references. Thank you.
Thank you, Rashmi. Very well presented and a nice topic. I request Shama ma'am and Kotalkar ma'am to throw light upon the topic.
Congratulate Rashmi for your study. The basic thing I wanted to ask Rashmi is, the only you have given 600 microgram once only.
Yes, ma'am. Yes,
and after that, you have sent her home and you have called her after 7 days. And
yes,
you said failure were only in 2 patients, they were incomplete abortion. After the days of 7 days, you have noticed she has a failure of this misoprostol. Isn't it? Is it so?
Yes, ma'am. Yes, ma'am.
Then isn't it because whenever there is an incomplete abortion, you need to evacuate immediately after even 48 hours if she has not passed the product. I think so. Here you should have called her earlier with the misoprostol group. One thing.
Ma'am, we will monitor them for 4 hours. If And if there is any excessive bleeding or foul smelling bleeding, the patient will be followed up and ask them to report as early as possible.
Because you have seen it followed up to 12 hours was the interval of delivery abortion, and this thing is 12 hours in few of the cases, isn't it?
Yes, ma'am.
So,
yes, ma'am.
So you have to call them after 48 hours to see whether the complete evacuation is done or not. I think so. This is one point. And secondly,
yes,
what I wanted to ask you, if any there is a complication of misoprostol, you have not monitored them at in your hospital. What are the complications of misoprostol, side effects rather?
Ma'am, misoprostol associated with the fever,
Yeah.
sometimes pain in abdomen, bleeding. If there is a profuse bleeding, will take patient for suction evacuation.
But you have you have not monitored them for more than 4 hours. So how will you see for this signs of fever and pain? Because they were at home.
Ma'am, before discharging, we tell them to report as if they find any of them sign or symptoms. So
because two patient has failed, na? So then does they have a foul smelling discharge or what it was? Do you have given
no, ma'am, after 7 days
cover for them?
After
Did you
7
give
days
cover to them?
Yes, ma'am. Yes, ma'am.
For how many days? 7 days?
Ma'am, for 3 days.
Okay. Over to Anju.
Well presented, Priyanka. One question is, what are the various routes of administration of misoprostol and which is the best route?
Ma'am, there are various routes of the misoprostol we can give by buccal, oral, and
buccal, oral, and what you say?
And with the different doses as well.
Buccal and oral.
Buccal, oral, and vaginal.
And fourth one?
Parectally can be given, ma'am, if the patient is bleeding excessively.
Which one you think is the literature? If you must have gone through literature because of your study, which one is supposed to be the best and most effective route?
Ma'am, per vaginal is the best route effectively, and which is also studied in a various studies.
The best route is sublingual, which you are not mentioning. The maximum availability of the drug is by sublingual and least is by oral.
Yes, ma'am.
Least is by oral. So that is one thing you can improve in your future. Suppose you want to continue with your research, you can change the route or even you can compare the route also.
Yes.
How do you clinically differentiate between incomplete and complete abortion, Rashmi?
Ma'am, in incomplete abortion, per speculum examination, we will get the product of conception may be present in a os. Os is open, and incomplete os is closed. And patient will have bleeding.
Which os you are talking about, Rashmi? Which
external os.
Is there any external in this? External os is more important.
Sorry.
Paras patient, external will always be patulous, remember. Yes. So whenever you say os, it is always the internal os. Well presented. Good. Well presented. Thank you.
Good. Thank you.
We can move to the next presentation.
Yes, ma'am. Thank you so much, ma'am. Actually, if this study gets really good proven, then it will be of great help for all of us to reduce our surgical interventions in cases of incomplete abortion, if it can be well managed with misoprostol. Moving on to our next presenter, Dipanjali. She'll be presenting a poster on Mermaid syndrome, Sirenomelia. Dipanjali, are we ready? Yeah. Please switch on your video also, Dipanjali, so that we can see you. Yeah.
Good morning, judges and my dear friends. I am presenting a case on Mermaid syndrome, cyanomelia, exceptionally.
Dipanjali, can you zoom it a little because it's not readable on the screen? Yeah, better. Thank you.
I am presenting a case of cyanomelia or Mermaid syndrome, exceptionally a rare congenital deformity. A 31-year female married since 7-year gravida for paraben live abortion 2 with previous LSCS scar came with a gestational age of 22 plus 5 weeks with USG report suggestive of single intrauterine pregnancy of 21 plus 5 weeks with intrauterine death with placenta reaching the os and no demonstrable fluid pocket seen. On further history, she revealed she had a 2 first trimester spontaneous abortion in which dilatation and evacuation was done in both the abortion. Here she had a 3rd pregnancy of full-term cesarean section in view of protracted first stage. She delivered normal fetal baby of female baby of 2.8 kg, now 5 years of old. In her present pregnancy, her first trimester USG ultrasonography was normal and her antenatal profile was normal. Second trimester USG shows placenta previa with unheterogeneous. She had no family history of any congenital anomaly. In our hospital, USG findings are confirmed. Additional to these, the tiny echogenic focus noted in left ventricle and bilateral renal agenesis. Right lower limb could not be assessed due to the severe oligohydramnios. From this, the diagnosis was made gravida for paraben live 1 A2 with previous LSCS scar with placenta previa with unheterogeneous with bilateral renal agenesis. On the very same day of the admission, the patient went in the labor, started contraction and started fresh bleeding previa passes a clot. Emergency hysterotomy was done. An anomalous dead fetus with joint lower limb, low set ears, imperforate anus and absent external genitalia was delivered. Further, the baby sent for the histopathological examination. They found the renal agenesis, absent urinary bladder, malrotation of intestine and single umbilical artery. From this feature, suggestive of cyanomelia was delivered. Step-wise devascularization was done during surgery and post-op period was uneventful. Congenital deformity, incidence of 1 in 1 lakh, fused legs giving the appearance of mermaid tail. This deformity is variably called as Simelia, Symphodia, Monopodia, and to its resemblance to the mermaid of Greek and Roman mythology called as mermaid baby. It is a lethal condition characterized by fusion of the lower limb, single umbilical artery, severe malformation of urogenital lower gastrointestinal tract, can occur as a separate entity or with a caudal degradation syndrome. Fatal within the day or 2 of life because of complication associated with abnormal kidney and bladder development and function. Etiology of this is unknown, although the environmental and genetic factors may play in the development of the disease. The diagnosis made by the ultrasound in a 2nd trimester, though it was missed in our case. There is one classification, Stalker and Hazel classification for cyanomelia, in which the type 1 to 7. In our case, it was a 6 present. The survival beyond the infancy into the latter childhood of young adulthood is reported in only a handful of cases. I am presented this case due to the rarity of this congenital deformity.
Okay. Thank you, Dipanjali. Indeed, it was a great case. What is the incidence of cyanomelia?
It is a 1 in 1 lakh, ma'am.
1 in 1 lakh. Okay. You said she had a placenta previa, so you did the hysterotomy, isn't it?
Yes,
why you have done the stepwise devascularization for this patient? Was she bleeding profusely, or just prophylactically you have done it?
Yes, ma'am. Yes, ma'am. Actually, she started bleeding.
Yes, placenta previa,
that's why prophylactically we like it. Yes, ma'am.
Yeah,
prophylactically.
Prophylactic. Okay. Was it needed? I don't think it was needed at all. Because she was just a 22 weeks pregnancy, isn't it? Anyway, Any another congenital anomaly which is at this age group we can rule out? After 18 weeks, we can come to know about any congenital anomalies. Okay. Over to Anju.
Deepanjali, well presented. What I want to ask is, what is the supposed pathophysiology or why it occurs? Why
It's
congenital malformation occurs?
There is an abnormality in the blastocyst formation, ma'am, and due to the single umbilical artery, which is continuation of the abdominal aorta,
what is the postulate? Whether it is whether it is seen in the family members, whether it is transmitted genetically.
No, ma'am.
What is happening here?
No, ma'am, there is no history of family or any congenital deformity.
In your case, it is not there, but whether it is likely to be seen in the close family members, whether the next pregnancy we need to, what counseling we need to do. So for that, we need to know what leads to. What is the underlying thought to be the reason for such a gross malformation?
Early antenatal visits and
so it is thought to be a mutation, Deepanjali, and it is one time. It doesn't recur. It is not seen in subsequent pregnancies, or it is not seen. It is not hereditary origin is not there. That is what I was expecting. What is caudal regression syndrome, Deepanjali?
caudal regression syndrome, ma'am, in which the sacrum and the spine was not developed. It is found mainly in diabetic mothers.
Okay. Any other, which one anomaly you tell me which needs to be diagnosed ultrasonographically by the end of first trimester? With the machines which we are having, ultrasonography machine, we should not be missing that congenital malformation. Which is that? So just find out, okay, about all the congenital malformations. Well done. Thank you.
Thank you.
Thank you, judges. Thank you, Shama ma'am. Thank you, Anjali ma'am. As a child, we used to enjoy the Mermaid cartoon, the Mermaid characters. But as a grown-up obstetrician, it is very saddening to see a mother with a Mermaid syndrome baby. So moving on to the next poster presentation. It will be by Dr. Mansi Jain. It will be, the topic is, the poster is on a rare case of abdominal pregnancy.
Yes, ma'am.
Yeah.
Yes, ma'am.
Sharing your screen. I request all the students to keep logged in even if you have finished your presentation, because this entire session is going to benefit you a lot. The entire presentation and plus the specialist discussion.
Yes, ma'am. Is it visible?
Zoom it a bit. Zoom it a bit.
Right.
You're not able to? Okay, start presenting.
Yes, ma'am. Zooming. Is it happening? Good morning, everyone. Today, I am Mansi Jain. I'm a resident of Gindri Abdominal Pregnancy.
Zoom it. Yeah. Zoom it.
Yeah, you were able to zoom, Mansi. You can zoom it further. Zoom it further. There will be a zoom option to you. Yes.
Yeah.
As you all know, abdominal pregnancies are the rare ectopic pregnancies with implantation in the peritoneal cavity, which primarily, if it's a primary abdominal pregnancy, will be exclusive of the tubal, ovarian, or interligamentous implantation. Primary implantation is actually very, very rare. For us to say it's a primary implantation, it should fit into the Studiford criteria, which says that there should be a presence of normal tubes and ovaries, no evidence of uteroperitoneal fistula, and presence of pregnancy exclusively attached to the peritoneal surface. Abdominal pregnancies are mostly secondary, where the primary sites are tubes, ovary, and the uterus. This secondary abdominal pregnancy mostly follows the early tubal rupture or abortion with reimplantation. In advanced extrauterine pregnancy, the placenta is found to be partially attached to the uterus or the adnexa. Clinically, we might feel abnormal fetal parts may be palpated and cervix might be found to be displaced. Ultrasonography is the investigation of choice in which we mostly find oligohydramnios, which is non-specific, and you might see fetus separate from the uterus or eccentrically lying in the peritoneal cavity. There would be a lack of myometrium between the fetus and the anterior abdominal wall or the bladder. Then the extra placental tissue will also be found outside the uterus, and bowel loops would be found surrounding the G-sac. As you can see in my figure image, the fetus is found outside the uterus. Treatment depends on the gestational age at the diagnosis. Conservative management is very risky because of the chances of neonatal malformations and morbidity if we decide to continue the abdominal pregnancy. Therefore, termination is the treatment of choice. Principal surgical objective involves delivery of the fetus and careful assessment of placental implantation without provoking hemorrhage, and unnecessary exploration is also avoided. Leaving placenta in place decreases the chances of immediate life-threatening hemorrhage at the expense of long-term sequelae. Basically, there are two schools of thoughts regarding leaving placenta in situ, because it is found that unnecessary exploration and placental removal may provoke serious hemorrhage and may lead to fatal conditions. Therefore, some prefer leaving the placenta inside, but it has been observed in various studies that there is more morbidity and mortality associated with leaving placenta in situ, as it might later lead on to abscess formation, fistula formation, and intestinal obstruction, adhesions, DIC, etc. So we had a case, a 25-year-old gravida 3 para 2 living to D1 with previous LSCS referred to us for persistent abdominal pain, which was increased since 2 days. On clinical examination, patient was pale, vitally stable. Systemic examination was within the normal limits. On per abdomen, there was a mass felt of 22 weeks size with palpable fetal parts. FHS was present, uterus could not be made out, and there was no palpable Braxton contractions. On per speculum examination, there was no bleeding and no discharge. We did her ultrasound. On ultrasonography, extrauterine abdominal pregnancy corresponding to the gestational age of about 20 weeks with fetal cardiac activity present was found, and minimal amount of free fluid in the pouch of Douglas and around the uterus was seen. And there was a presence of an empty uterine cavity. Placental attachment could not be delineated. Patient was evaluated further. Consent and grave prognosis of the mother and the baby explained, and blood arranged. On day 5 of admission, our patient had complaints of sudden pain in abdomen, signs and symptoms of hypotension and tachycardia present. Patient was taken for emergency laparotomy under general anesthesia. Paramedian incision was made. Patient delivered 500 gram male IUD out of the abdomen, as you can see in the figure 2. Umbilical cord was seen lying freely in the abdominal cavity and was traced up to the placenta. Hemoperitoneum was present of around 1.0, and which includes around 400 cc of clots. There was evidence of ruptured broad ligament along with sac membranes. Evidence of separated surface of the posterior leaf of broad ligament. As in my figure image 3, you can see the uterus, and on the left side of the uterus, there are 2 leaves of the broad ligament, right side, and which is found attached to the posterior leaf of the broad ligament. Left-sided fallopian tubes and broad ligaments were normal. Bilateral ovaries were normal, which rule out our ovarian ectopic. Right-sided tubo-ovarian ligament was clamped, cut, and ligated. Figure 6 shows the post-ligation image of the right-sided broad ligament and ovary, tube-ovarian ligament. 2-pint whole blood was transfused. All the tissues are sent for HP. Patient was stable post-operatively with no complication and was discharged after 10 days in the stable condition. So I would conclude by saying that abnormal pregnancy is a challenge to obstetrician due to its rarity, varied presentation, and intraoperative complications like postpartum hemorrhage. But if we are well aware about its clinical conditions and with good surgical skills, we can prevent unfavorable and fatal consequences. Thank you.
Thank you, Mansi. Well presented. Over to Kshama ma'am and Anjali ma'am.
I congratulate you, Mansi, for such an excellent case, and actually the diagnosis part of it. Basically, diagnosis is very important. I wanted to ask you one question on this. Was it attached to it was a rupture of the broad ligamental pregnancy, or it was just attached to the broad ligament?
No, ma'am, it was actually the placenta was halfly found to be attached. It can be a secondary diagnosis of rupture of the broad ligament of the pregnancy, broad ligament pregnancy.
So it may be in the broad ligament and it has
Yes,
ruptured, and that's why
yes,
1.5 liter of hemoperitoneum is
yes,
there.
ma'am, and that's why the patient was initially stable with us for 5 days, and suddenly she complained of sudden pain in abdomen and tachycardia. So we can suspect a rupture on day 5, and which can lead to hemoperitoneum.
So it is a broad ligamental pregnancy. Okay. Then how will you rule out normal pregnancy from an abdominal pregnancy? Can you tell me?
Normal pregnancy, ma'am, first of all, clinically, we will feel the fetal parts are more palpable than the usual. Then on the cervix might be found to be displaced. Then sonographically, there would be empty uterine cavity. Then there would be lack of myometrium between the fetus and the anterior abdominal wall. Fetus would be seen separately, separate from the uterus or eccentrically lying. And there would be extrauterine presence of the placental tissue, which can be confirmed with the Doppler finding also. And there would be bowel loops surrounding the GSAT. And for further confirmation, we can go up to the MRI, which can give us the clear picture about the placental implantation.
But was this the only sonography she has done, or
yes, ma'am, no.
She has not done in any first trimester?
No, ma'am. She only came with the complaints of amenorrhea since 2 months and pain abdomen. Patient was not aware of her pregnancy.
To explain amenorrhea for 2 months only?
Yes, ma'am. Sorry, amenorrhea of 4 months.
4 months. Okay. So she had given amenorrhea 4 months with the pregnancy outside the uterine cavity. But don't you think it should have ruptured earlier? Ideally, it should have ruptured earlier, not going up to the stage of 25. What is the weeks of pregnancy? 20 weeks.
20 weeks, ma'am. 20 weeks.
It had gone up to the 20 weeks. Isn't it too really risky? I had never seen baby going up to the 20 weeks in outside uterus. Okay. Good presentation, Mansi.
Thank you.
So Mansi, my question is, what was done about the placenta? What you said?
Ma'am, placenta was removed completely.
Removed. Now,
yes,
suppose you are, what are the situations where you will take a decision not to remove the placenta in abdominal pregnancy?
When is it, ma'am, when it is adhered mostly to the peritoneum, or when the removal is when the removal might lead to dangerous hemorrhage like conditions, there we can make a decision of leaving the placenta in situ, and then we'll follow up and monitor the patients with serial beta HCG and USG. Usually beta HCG would regress to normal within 4 months, that is 50 days of the placental activity. And there is another theory about giving post-op methotrexate to accelerate the placental necrosis, which is also controversial, ma'am, as it might lead to the necrotic tissue for, collection and later abscess formation, and later leads to peritonitis and increased morbidity and mortality.
So methotrexate also has its own complications, isn't it?
Yes, ma'am. Yes, ma'am.
It's always better to
So there
remove it.
must be the implantation in your patient. What do you think?
On the posterior leaf of the right side of broad ligament, ma'am. Placenta was partially attached there, so it was
How
a
it will
secondary.
go to the broad ligament is my question to you, Mansi. How it will go to broad ligament? Any pregnancy?
From the ma'am, when the implantation is towards the mesosalpinx side, it might rupture and go up to the broad ligament.
From the floor of the, isn't it? Must be the
Yes.
tubal pregnancy rupturing towards the
Yes, ma'am.
floor,
Yes,
base, isn't it?
Yes,
Was there any sign of rupture of the tubes or anything there?
No, ma'am. No, ma'am. There was no signs of bilateral tubes and ovaries were normal. And this is the picture which showing no rent on the uterus. Figure 7 has showing the no rent over the uterus. Yes.
Congratulations.
Nice presentation. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, Kshama ma'am and Kotalkar ma'am, and thank you, Mansi. I would like to now invite our next presenter, Dr. Ashwini Najan, who will be presenting a poster on a case of MRSA wound infection, potential outbreak and its prevention. Ashwini, unmute yourself. Yes. A little zoomed out picture. I mean, zooming picture. Yeah, it is better, but then you'll have to slide the screen so that everybody is able to read what you are showing. This is better. No, earlier was better, Ashwini. Yes, okay. Now you can proceed.
Good morning, everyone. I am presenting a poster on a case of methicillin-resistant Staphylococcus aureus wound infection, a potential outbreak and its prevention. There is a worldwide increase in prevalence of virulent bacteria that are resistant to multiple antimicrobial treatments. One strain of antibiotic-resistant bacteria which is associated with disaster post-operative wound infection is methicillin-resistant Staphylococcus aureus. MRSA colonizes the skin and open wounds, interferes with wound healing, increases the morbidity of the patient due to spread of the infection, and further may lead to nosocomial infections to other patients. Studies report increasing prevalence of community-acquired MRSA worldwide. Decreased vancomycin susceptibility and multi-drug resistance complicates the infection and treatment. The objective of presenting this case, hereby presenting a gynae case with post-operative MRSA wound infection which lead to massive necrosis of abdominal wall, increased morbidity and hospital stay, and ultimately requiring vacuum-assisted closure, that is VAC. The objective of presenting this case is to discuss the importance of screening of MRSA and its strict surveillance to limit its circulation and spread. The case is as follows. Mr. C, 60 years old, postmenopausal since 20 years, complaints of excessive discharge per vaginum increased since 3 months, with good general condition, hygiene, and nutritional status. Per speculum, the cervix was posterior, flushed with vagina, minimal bleeding on touch and senile vaginitis. Per vaginal, uterus was retroverted, 10 weeks size, mobile, and both fornices were free. She was diagnosed as carcinoma endometrium stage 3C1, for which she was operated for uterine cystectomy, which was uneventful on 27th August 2019. HP report was suggestive of poorly differentiated adenocarcinoma. Investigations include complete blood count and sugars were normal. USG was suggestive of bilateral ovaries normal and polypoidal intraluminal mass present in endometrial cavity. CECT was suggestive of neoplastic etiology of the cervix with Pyometra in uterus, multiple enhancing lymph nodes along bilateral iliac vessels. ECC was suggestive of adenocarcinoma arising from the endometrium or endocervix. The series of events which takes place are as follows. Uterine hysterectomy took place on 27th August, for which the patient received ciprofloxacin metronidazole for 7 days. On post-op day 8, she had 1 episode of fever, dressing was soaked, and induration was present till 5 cm above the wound. Local temperature was not raised. Therefore, the stitches were removed and patient received tablet linezolid for 10 days. On post-op day 9, blackish discoloration about 2 centimeters of the wound and induration was present to about 5 centimeters above the wound. Minimal serosanguinous discharge and full gape was present. Dressing was done and USG was suggestive of wound inflammatory changes noted in the subcutaneous fat. The patient received tablet augmentin for 4 days. On post of day 11, there was spreading cellulitis, and the culture showed MRSA resistant to augmentin. It was sensitive to vancomycin linezolid. Patient was isolated, and patient received injection vancomycin for 7 days. On post of day 14, wound debridement was done in OT by surgeon. And post of day 18, wound debridement was done in OT by plastic surgeon, which along with back dressing with split skin graft from right thigh. Prolonged urinary bladder catheterization was done, for which she received injection ceftriaxone for 7 days. On post of day 25 and VAC day 7, the VAC was removed and patient was febrile for 2 days. Urine culture was positive for Klebsiella. Therefore, the patient was started on tablet staph cure for 7 days and dressing was continued. The steps taken for hospital infection control for MRSA were: the patient was isolated in side room, ward was fumigated, patient swab was sent from the cultures, came positive for MRSA. After the index case, 2 more patients came positive for MRSA in 2 consecutive weeks. This image for the second patient for MRSA positive is given above. After all the treating doctors were screened, 1 senior resident and 3 junior residents swab came positive. Decolonization of all the patients and doctors were done. Universal screening of patients was started for all gynecological cases, and many patients from community were found to be positive. CDC estimates that MRSA is responsible for more than 7,000 severe infections and 9,000 deaths per year. On identifying the index case, urgent phylogenetic analysis is needed to define the possible route of acquisition of MRSA wound infection, to understand if the patient has been infected by a nosocomial cause or was a community carrier. Rigorous management with wound debridement and antibiotics to be done. Prevention is better than cure. Therefore, source control stands most important. Horizontal and vertical infection control strategies should be adhered in every healthcare facility. Horizontal infection control includes use of proper hand washing, gowns, and gloves. Vertical infection control includes active surveillance testing and decolonization. Active surveillance testing is collection of samples from nose, throat, armpits, rail beds, finger webs, groin, or perineum. Is recommended for high-risk patient populations before taking for any elective surgery. MRSA decolonization of positive screen patients with mupirocin ointment and daily bathing with chlorhexidine gluconate is recommended. Conclusion is that make preventive staphylococcus infection a priority in healthcare facilities. Assess your facilities data, implement prevention actions, and evaluate the progress. Thank you.
Thank you, Ashwini. Now I invite judges for their questions.
Thank you, Ashwini. It was a nice presentation. Can you tell me what is the incidence of such a infection in patients? What is the incidence of MRSA? Hello.
2 to 3%.
How much is the incidence?
2 to 3%.
3%. Okay. From where you have got this incidence? Okay. Now you tell me one thing, Ashwini. You have applied this VAC, isn't it? So, but was that infection was so severe that you have to apply this VAC?
Yes, ma'am. It has spread to the 5 centimeter above the incision, and it has 5 centimeter above the incision.
5 centimeter above the incision, it has spread. So you have taken this decision of applying it. Okay. And how was the result of this VAC?
Ma'am, it was effective, and the VAC was removed after on day 7.
Day 7. Okay.
Yes.
And how should you prevent this MR and this infection?
Ma'am,
yes.
Ma'am,
what precautions should be taken? You only said the prevention is better than cure.
Yes,
So
ma'am.
what precautions should be taken to prevent such infections?
There should be horizontal infection control and vertical infection control is there. Horizontal infection control is not species specific. It includes washing of hands, gloves, and wearing of gloves and gowns. And vertical infection control is species specific. It includes the active surveillance techniques like collecting the samples from the patients, like armpits, groins, finger webs, and sending it for culture. And it also consists vertical infection infection control also consists of decolonization. Decolonization includes the topical application of chlorhexidine and piperacin ointment.
Okay, over to Anju.
Was it hospital acquired infection, you think, Ashwini?
Ma'am, ma'am, I
Could
think
it
it was
could
community.
it have been, as per your presentation, 2 more patients presenting in the successive same duration? Is it a possibility that it is
Yes.
hospital acquired infection?
Yes, ma'am.
So what are the common hospital acquired infections we should be aware of as surgeons?
E. coli. Ma'am, E.
What are the
coli.
various hospital acquired and very common hospital acquired infections which we encounter?
Staphylococcus aureus Staph aureus infections. E. coli infections. Clostridium infections.
Commonest in hospital like us is a ventilator associated pneumonia is number 1. Then you can have COTI. COTI is catheter acquired UTI. And third is SIS, that is surgical site infection. SSI, surgical site infection. These 3 are the commonest, and MRSA also is one of the hospital acquired infection only. What is antibiotic stewardship program? This is related to the most important and interlinked topic is with this hospital acquired infection is antibiotic stewardship program.
Okay.
As the rationale is misuse and overuse of antibiotics, and we see such type of outbreaks. MRSA outbreak is a rare event, but the underlying it might have some iatrogenic origin. It can be with a prolonged, unnecessary overuse, misuse of antibiotics. So which prophylactic antibiotic was given to your patient?
Ma'am, vancomycin was given. Injection.
I am asking you which prophylactic antibiotic. You understand? Prophylaxis. Every patient you give antibiotic when you take the patient for surgery, isn't it?
Yes, ma'am.
Whether you take for any surgery, you give some antibiotic, that is prophylactic. So which prophylactic antibiotic was given in your case?
Injection ciprofloxacin. Injection ciprofloxacin.
Ciprofloxacin was given as prophylactic.
Yes, ma'am.
When will you give prophylactic antibiotic? Ideally, when should you be giving? As per the incision, when you are giving the incision related to that timing of incision, when should the prophylactic antibiotic be given?
Half an hour.
Suppose you are doing any surgery, also, when should be which is the ideal time to give prophylactic antibiotic?
Half an hour before starting the surgery.
Why? You are right. Why? Okay. So read about this. How should be the correct use of antibiotics? Yes.
Now it is effective only for 3 hours.
For how many days do we prophylactic antibiotics postoperatively?
Ma'am, for 2 days.
For 2 days?
Which is your reference? Say 2 days. Which is the reference?
I'm 7 days, sorry,
So
7
I
days.
think you need to read more about the correct use of antibiotics as well as hospital acquired infections, but well presented. Thank you.
Thank you, ma'am.
Thank you. When we see such dreaded cases of surgical site infections, then we realize the importance of our first day of our residency program, when we are taught of hand washing, doffing, donning. So the importance of pre and post-op care. So thank you, judges. Moving on to the next case, it will be by Shraddha Rao. She'll be presenting poster on acute fatty liver of pregnancy. Shraddha?
Yes, ma'am.
Yeah, please share your screen and switch on your video too.
एक तास झाला ना 1 2 3 4 5
Again, AFLP is an entity in pregnancy where we've seen so many fulminant cases, the MAT-MOD, the morbidity, the detection itself. Actually, it is so late, the symptoms are so subtle. Usually patient comes in such a fulminant position. So again, learning about it through a poster by Shraddha. Let us see what she is presenting new or the points. Ma'am, any recent updates to Shama ma'am and Anjali ma'am regarding any screening protocols, newer things been added for screening any AFLC, AFL, acute fatty liver of pregnancy cases in pregnancy?
Can you speak clearly? I really did not get any question from.
Okay, actually, I've been asking, are there any screening, any screening procedures where we can just pick or screening blood test or screening ultrasound things where we can pick liver disorders in pregnancy at the initial
We'll
level
discuss
only?
later on, Amrita. Let it be.
Yeah.
Let it be. Let us present. You can discuss the previous
Shraddha is
case.
taking to upload. I thought let's have a discussion on this important topic as well.
Anything
You will ask her only and we will let get the answer.
We can talk on the topic which was presented, a case of MRSA wound infection. Actually, after having this outbreak of MRSA wound infections, we had started as a routine protocol of taking MRSA swab of every patient. So we used to take 5 areas of the body and we used to take the MRSA swabs, and if she was MRSA positive, then we used to delay the elective procedure to be done. And even the surgeons in that situation, even the surgeons swabs were taken and they were also scrutinized.
It's a mostly it means it is a hospital acquired infection, isn't it? You have to see for your hygiene from the hospital point of view only. The swab, OT swab is more important for this point of view.
Hand washing, Shama.
Washing
and bypass
exactly.
washing
They only
just
scrub only for a 2 seconds, rather 2 to 10 seconds. They finish of their scrubbing. It's really their hygiene is very much important in maintaining such a cleanliness in the OT also.
I think so. Every 6 months, there should be review courses for these residents for us. There should be a senior matron sister who should be supervising us whether we are, actually washing
properly, scrubbing or not. Yeah.
Yes.
Even after scrubbing, actually, even after scrubbing, like while wearing the OT gowns, the scrubs, even at that time also, every resident should be trained.
Yeah, actually.
In Netherlands, they have a machine. With the machine, that machine will show the area of the hand which is not properly washed. It will
Is there such machine?
Red patch will be you are not washing the back side of the fingers, for example.
So
there is random testing of all the surgeons, random testing of all the people who are coming in contact.
So everybody will be watchful and careful Not
Yeah.
to take steps.
And invariably, there will be few areas because that is the human way of doing it. You don't do the, you do hand washing, but you don't do the careful hand washing.
Proper we don't do.
7 steps we do.
And actually we blame the others, means not keeping OT clean or unhygienic OT. We blame to all these things, but actually we are at fault.
At fault, yeah. Right. I think
Okay,
so.
let's
Shraddha
move
is
to
ready.
Shraddha.
Yeah. Shraddha, please start. Shraddha, are you able to do it?
Hello.
I guess Shraddha is taking time. So can we move ahead for the next case, ma'am, till then?
Yes.
Priyanka Thakur, I invite you for the next paper presentation on cervical fibroid, a challenge. Priyanka, are you ready? Priyanka, please unmute yourself. Priyanka, have you unmuted? Shraddha, stop sharing your screen so that Priyanka can do her screen sharing. Yes, Priyanka, we can see your video. Yes, you have started sharing your screen. Make it in slideshow. Go in slideshow.
It's your time.
Yes, we can see it, Priyanka. You can start your presentation.
Good morning, everyone, teachers, delegates, and my friends. Today, I'll be presenting my paper on cervical fibroid, a challenge. It is the most prevalent uterine pelvic tumor is leiomyoma. It affects 20% of the women in their reproductive years. However, only 1 to 2% of cases are located in the cervix. Cervical fibroids generally appear in the supravaginal region of the cervix. The most common symptoms are urinary retention, menstrual irregularities, constipation, and in certain cases solely an abdominal lump. Large cervical fibroids are uncommon, but they can cause complications during myomectomy or hysterectomy, as well as increase the risk of urinary tract injury and intraoperative bleeding. In this study, 48 examples of big cervical fibroids in women with parities ranging from 1 to 3 who successfully underwent hysterectomy and myomectomy have been taken. In addition to careful dissection of the ureters and bladder, clamping any pedicle and keeping the ureters under direct vision and dissection and enucleating a large fibroid, whether cervical or uterine, by limiting the dissection to within the capsule of the fibroid is the key surgical technique to prevent ureteric injury. We end by stating that big cervical fibroids are a very unusual occurrence and it requires a skilled hand to operate on, and in order to minimize blood loss, avoid unintentional harm to the ureters or bladder and adhere to all the Victor Boni surgical guidelines. Uterine fibroids, as we said, accounts for more than 20% of the fibroids, whereas cervical fibroids accounts only for 0.5 to 1% of all fibroids. It can develop either in supravaginal, vaginal region of the cervix. They are categorized as anterior, posterior, lateral, or central, depending upon where they originate from. Each fibroid has its own clinical manifestations, such as menstrual irregularities, severe urinary retention, constipation, and so on. They can alter the form of cervix and even stretch it. The uterus may be pushed higher or the cervical canal obstruction if the cervical fibroid develops fast. Because of the location, presentation is typically uncommon and removal is more difficult. Rationale in this study is there is lack of data in principle of surgery in women with cervical fibroid, putting surgeons in a bind, which is why this paper was written. method used was a prospective study was done at our tertiary healthcare institution. A total 48 women were taken in this study with cervical fibroid and were investigated and operated. Preoperatively, a detailed history was taken that included demographic information, common clinical symptoms, clinical examination findings, imaging modalities for diagnosis and evaluation of the fibroids and the ureters. The surgical treatment modality was planned, as well as the intraoperative finding and complications were studied and analyzed. A total 48 women with cervical fibroid were treated in this research. The women ranged age from 32 to 44 years of old. The most prevalent symptom was a lump in abdomen, and the biggest cervical fibroid removed was a 27 centimeter long multi-lobed fibroid. This is a chart for demographic data of cervical fibroid. 15 of the 48 women diagnosed with cervical fibroid are either anterior, central, or posterior fibroid. The most crucial diagnostic symptom on examination are that these fibroids have restricted movements in the abdomen and that the cervix is retropubic and effaced. This is a table showing cervical fibroid, types of cervical fibroids in women: anterior, posterior, central, and multiple. Cervical fibroids are difficult to treat, and just 3 women have undergone myomectomy for anterior and posterior cervical fibroids. These women had prophylactic internal iliac ligation to reduce the blood loss, which was done in accordance with the principle of blood loss reduction, including the use of vasopressin. TAH with BSO was performed in 37 other women. The most frequent injuries are hemorrhage, bladder, and intestinal injuries. We had fewer complications in our study because we followed Victor Bonnet principle for cervical fibroid surgery. These are the complications. The most common complication was primary hemorrhage. Discussion. Cervical fibroid can be as follows. It can be categorized as anterior fibroid, where the tumor arises from the superficial muscle of the anterior lip of the cervix and bulges forward and puts the bladder at risk. Posterior fibroid, where the tumor arises from posterior part of the cervix. It flattens the pouch of Douglas backwards, compresses the rectum against the sacrum, or in the rarer form, undermines the peritoneum in the bottom of pouch of Douglas and obliterates the cul-de-sac. It lifts the serous membrane of the anterior surface of the rectum and sacrum and pushes down between vagina and rectum. Then there's lateral cervical fibroid, where the myoma burrows into the wide ligament and stretches it, commencing on the side of the cervix. Then there's central fibroid, where a tumor, whether interstitial or submucosal in origin, expands the cervix in all directions equally. A central cervical myoma is easily identifiable because the pelvic space is more or less filled by the tumor, with the uterus raised on top of it like the lantern sitting on top of St. Paul's dome. Finally, cervical myomas can also be in groups. Understanding the strategy for removal of these tumors require knowledge of their anatomical linkage. We can minimize the complications by following a protocol. Counseling, consent, arrangement, and issuing adequate amount of blood are all prerequisites. This is a chart for showing surgical techniques in different women. Steps of surgery for myomectomy. First of all, we open the abdominal cavity and we open the peritoneum as high as possible, as in anterior cervical fibroids, bladder may be advanced. Examining the abdominal packing of the intestine is done, clamping and dividing the ovarian vessels and round ligament very close to the uterus. Dissecting down the anterior flap of the peritoneum and pushing the bladder down. Ascertaining the plane of cleavage by incising into the substance of the fibroid. Enlarging the incision in the capsule, enucleating the tumor using bony screw and sharp dissection and removal of fibroid is done. With this, the anatomy gets restored, and then do the ligation of uterine vessels, Mackenrods, and uterosacral ligaments. To avoid harm to the ureters and bowel, always stay intracapsular. Open retroperitoneum for direct visualization of ureters. We conducted preoperative ureteric stenting in 2 of our patients and removed the stents 6 weeks later. For decreasing the bleeding from fibroid bed, prophylactic internal iliac ligation was done in 5 women with large central cervical fibroids. The cervix is effaced, therefore opening the vagina requires caution and patience. Wall suspension is accomplished by connecting the angles to the uterosacral ligaments as is customary. After achieving good hemostasis, abdomen closed in layers. An anterior cervical myoma can take 1 or 2 of the more forms. It can undermine the bladder and elevate it on its upper surface, and it can force its way up between the peritoneum covering of the bladder posteriorly and musculature of the viscera. Therefore, open utrovesical fold of peritoneum and push the bladder down. Central cervical myomas are typically best removed with hemorrhage, followed by hysterectomy, but Rutherford Morrison developed approach. Difficulties faced were the most important to get into the plane of cleavage between the tumor and the capsule of expanded cervical muscle. Otherwise, troublesome bleeding and risk of organ damage is always there. Then we should always stay intracapsular and avoid harm to the bladder, ureter, and intestine. In conclusion, large cervical fibroids are uncommon, but they might pose a surgical challenge when myomectomy or hysterectomy is performed because the fibroids distort the uterine anatomy. In addition to careful dissection of the ureter and bladder, dissecting and enucleating a big cervical fibroid by confining the dissection to within the capsule of the tumor is a significant surgical method to minimize the ureteric injury. Large cervical fibroids are an uncommon occurrence that necessitates a skilled hand to operate. We should always follow the Vesico-uterine surgical techniques to minimize the blood loss and avoid unintended trauma to the ureters and bladder. The problem anticipated during hysterectomy for a cervical fibroid are displaced uterine vessels and normal anatomy of the ureter and bladder. Therefore, chances of injury to ureter, bladder, and uterine vessels are more likely. Preoperatively, assessment and estimating the intraoperative blood loss can help decreasing morbidity. Victor Bonney had ability far above those of most humans, allowing him to function at the greatest level possible, and they're capable of putting those thoughts on paper in form of clean and second sketches. Practice and analysis are the key to accuracy and skills. With focus and self-control, surgery should be one continuous process with no stops. Thank you. That will be my paper.
Now I invite the judges for the questions, please.
Yeah. Congratulations, Priyanka, for an excellent study. You had really extensive study for 4 years. You have done it.
Yes, ma'am.
Indeed, something different. I would like to ask you 1 or 2 questions regarding this. You have done only 1 vaginal myomectomy in these cases, isn't it?
Ma'am, 3 vaginal myomectomy were done. 2
were abdominal and they said, and 1 were vaginal. Your
yes.
chart said. Anyway, was it means all other cervical fibroids were small so that you have to do it TH or
ma'am, most of the women were around postmenopausal age group, so and
decision of TH.
Decision of TH was taken.
Okay, you said you have done an internal iliac artery ligation.
Yes, ma'am.
Means before removing myoma or after removing?
Ma'am, it was, yes, ma'am. It was done after removing the myoma so that the space is better. And
because it is really difficult to remove it, do it before removing the myoma.
Yes, ma'am.
One question, you are a postgraduate student?
Sorry, ma'am?
Are you a postgraduate student?
Yes, ma'am. I'm JR2.
JR2. Okay. Tell me, how will you, because these are mostly whenever cervical fibroid present, you got big cervical fibroid because you have up to the very big 24 centimeter also you have removed. I wanted to ask you, they sometimes eat necrotic, ulcerative and all those things. So how will you differentiate between a chronic ulcerated inversion with this myoma, necrotic myoma?
Ma'am, necrotic myoma patients will technically like they'll present with toxic symptoms, like there will be infections in acute.
Differentiating between a chronic inversion and a cervical fibroid, I want to ask you.
Chronic inversion and cervical fibroid. Cervical fibroid, like on per vaginal examination, we can differentiate.
How?
Because in cervical fibroid, the cervix will be effaced, the uterus will be sitting
cervix
on top
goes up, no? So most of the time cervix is very high up. So how do you?
Yes. Cervix is high up, and the uterus, like if there is chronic inversion, then we won't be able to feel the uterus.
What you are feeling uterus on
per vaginal examination.
Okay, you will not feel the uterus at this normal place. You will feel there is an empty space there.
Empty space.
Okay.
And in cervical fibroid, uterus is mostly sitting on top of the fibroid.
Okay. Okay. Go ahead with Anju. Over to Anju.
Ma'am, you're not audible. Unmute your mic, ma'am.
Okay, I'm sorry. Priyanka, how many were from portio vaginalis and how many were supravaginal origin in your study?
Ma'am, in my study, mostly fibroids were posterior fibroids were there.
I'm asking you,
Yes, ma'am.
cervix has two parts, isn't it?
Yes, ma'am. Supravaginalis.
Portio-vaginalis and supravaginal part.
Yes, ma'am.
So how many were arising from portio-vaginalis part of the cervix? How many were from supravaginal part of the cervix?
1 minute. Supravaginal, maximum were, ma'am, from portio-vaginal cervix. Only few were, 3 were supravaginal.
Nice presentation. Thank you.
Thank you, ma'am.
Thank you, Priyanka. Thank you, ma'am. Thank you, Anjali, ma'am. Before we move on to our last presenter, I would like to acknowledge presence of Pushpa Jungare, madam, judge for our next session. We are really sorry, ma'am, for the technical glitches and the delay for 5-10 minutes more. Kindly bear with us. Yeah, moving on to the next presenter, Shraddha Rao, presenting a poster on acute fatty liver of pregnancy. Shraddha, unmute yourself and share.
Good morning, respected seniors and my dear colleagues. I'm sorry for the technical glitch earlier. I'm here to present a poster on acute fatty liver of pregnancy masquerading as HELP syndrome, prepared with the help of my guide, Dr. Somalwar and Dr. Rohini. Acute fatty liver of pregnancy is a rare, potentially fatal complication that occurs in the 3rd trimester or early postpartum period. I would like to discuss a case here where a 20-year-old primary gravida with gestational age of 36 weeks presented with complaints of pain in abdomen, blurring of vision, vomiting, BP reading of 170 by 90 millimeters of mercury. Magnesium sulfate was given as the provisional diagnosis was taken to be severe preeclampsia with HELP syndrome. The patient was taken for emergency LSCS in view of fetal distress with meconium stained liquor. The patient delivered a male baby. The patient had a deranged liver panel. On day 2, the patient was drowsy and minimally responsive to commands. The random blood sugar was done, which was 52, which led us to a diagnosis of acute fatty liver of pregnancy. On the days to follow, the patient had a worsening liver panel and renal function. The patient developed abdominal distension, anasarca. Eventually, the patient went into cardiac arrest and the patient could not be revived. Here is a table depicting the various distincting points between the differential diagnosis. In acute hepatitis, we would find that we marked elevation of the transaminases. In cholestasis of pregnancy, we would find marked pruritus. As evidenced in the table, there would be elevation of transaminases in HELP and in acute fatty liver of pregnancy. Both would have similar symptoms of nausea, vomiting, abdominal pain. There will be marked thrombocytopenia in both HELP and in AFLP, which is why I said that it was masquerading as HELP syndrome. The incidence is 1 in 10,000. With complete supportive care, recovery is usually complete. Mortality used to be believed to be 75%, but present studies have shown that the mortality is now 15 to 25%. It manifests late in pregnancy. It is believed to be a recessively inherited mitochondrial abnormality of the fatty acid oxidation. We use Swansea criteria for diagnosis, which includes vomiting, abdominal pain, polyuria, polydipsia, encephalopathy, bilirubin of more than 14, hypoglycemia, urea, leukocytosis, elevated transaminases, elevated ammonia, creatinine, elevated creatinine. Persistent nausea and vomiting are the major complaints that patient presents with. Liver biopsy is used for confirming the diagnosis, which could not be done in our case as the patient presented very late to us. There is evidence of hemolysis. Hypoglycemia is very common. Delivery is believed to arrest the liver dysfunction, which is why it is believed that the patients usually recover 3 to 5 days post-delivery. I would like to conclude by saying hypoglycemia in a pregnant woman without overt or gestational diabetes mellitus, along with a deranged liver panel and thrombocytopenia, should give us a clue in diagnosing acute fatty liver of pregnancy. We should focus as much on hypoglycemia as much as we do focus on hyperglycemia in pregnancy. Timely diagnosis and intervention can help us in reducing maternal and perinatal mortality. Thank you.
Now I invite the judges for the questions.
Yeah, I congratulate you, Shraddha, for excellent presentation. Now you say how many patients you have seen with this acute fatty liver patients in your college? What is the incidence, or rather in general, what is the incidence of this?
Incidence in general is 1 in 10,000. I have happened to see just one case as of today.
Only you have seen in the one case. Okay. And what is the differentiating point between this thing, acute liver and health?
The main differentiating feature is hypoglycemia, which is seen in acute fatty liver of pregnancy. Apart from that, the transaminases are markedly raised in HELP syndrome. In acute fatty liver, we would find them to be moderately elevated. We would also find hemolysis in acute fatty liver. Hemolysis will be evidenced by leukocytosis and thrombocytopenia, which is not as marked in HELP syndrome.
Okay. Over to you, Anju.
Shraddha, suppose you get an antenatal patient, early you diagnose it as fatty liver. What should be the mode of delivery and what precautions you will take?
We can give a trial. We can give trial of normal delivery up to 24 hours, but most of these patients end up having a cesarean section, as complications of acute fatty liver also include metabolic acidosis in the mother, which eventually will cause a fetal acid-base disbalance, which is why we would try to terminate the pregnancy as soon. So we give a trial for 24 hours for normal labor, or we would proceed towards cesarean section.
What precautions you will take? You are taking the patient for cesarean. What complications you expect? What precautions?
We will try to arrange. We will arrange platelets, as we would expect her to have thrombocytopenia. We would arrange. We would arrange her blood. We would want a speedy. We would want a speedy report of the lab investigations, so that we can proceed. So that it can help us appropriately in diagnosing.
Okay, well presented. Thank you.
Thank you.
Shraddha, thank you so much. Thank you so much, Kshama ma'am and Kotalkar ma'am. Kshama ma'am, we are really thankful for you for getting so much of, because of technical glitches, we had to face many problems and we were delayed by almost like half an hour, but still you cooperated so well with us, and as a mother, you took all our glitches with you and you have guided us so well. Thank you so much, ma'am.
Thank you, dear. Both of you, you are really excellently conducting this session. I really congratulate Anuja Bhalerao madam for an excellent training of you all. Really, you people are doing a great job. Thank you very much for making me a part of your PGCON. Thanks.
Thank you, ma'am. And thank you, Kotalkar ma'am. As usual, you have been our mother for guiding us in all things wherever we need documented principles, any legal matters, legal issues with all clarity. एक बार कोटालकर मैम ने बोल दिया तो फिर हमें कोई स्ट्रेस नहीं होता है. Yes, this is the red line for us. Thank you so much, ma'am.
Thank you. Thank you. Well done, both of you.
Thank you.
Thank you, ma'am. Thank you. Now already we are quite a bit delayed, but still better late than never. Let's move on to our next session, the last session of the day. And I invite Pushpa Jundare madam, a professor and head of the Department of OBGY at PDMC Amravati. She's been affiliated to multiple bodies. She's a member of UG and PG Board of Studies of Surgery and Medicine, MUHS. She's a past president of Amravati OBGY Society, organizing chairperson for MOGS 2020 at Amravati, peer reviewer for the Journal of Obstetrics and Gynecology of India. Awards, she's been awarded with multiple awards, national and international awards to feather her cap, popularized NDVH in Amravati region, MOGS Ratna Award for efforts towards women's health in India, International MS Signature Award for phenomenal leadership in academia and providing excellent emergency obstetric care in the community. She is one of the principal investigators in the uterine balloon tamponade and PPH bundle project in collaboration with Howard University, US. I welcome you, ma'am. Next, I welcome, ma'am. Next, I welcome Savita, ma'am, Savita Sumarma, ma'am. She's associate professor at NKP SIMS Nagpur. Madam has been an undergraduate and postgraduate teacher with a teaching experience of 25 years. She has many national and international publications to her credit. Madam has also been a certified instructor of American Association of Family Physicians for BLSO and ALSO. And very soon, Madam has been starting the courses here at our center. She is also a trainer for PPIUCD program and always an enthusiastic academician helping the postgraduates. Welcome you, ma'am. Now I invite our first presenter, Dipanjali Tumjare. She will be presenting paper on the topic neutrophil to lymphocyte ratio and platelet to lymphocyte ratio in preeclampsia, a case control study. Dipanjali, would you please share your screen? Dipanjali, are you here? Yes. You can start your video also, Dipanjali. I think so some time is there. Sumara, ma'am? Internet issue. Yes, ma'am. Could you please switch on your video also, ma'am? Sumara, ma'am. Dipanjali, start sharing. Your screen is not seen. Dipanjali, are you ready with your thing, or you will take some time? Please let us know.
I think there is some internet issue on that side.
Okay. Yeah, Dipanjali.
No.
Dipanjali, are you able to hear us? Okay, in the meanwhile, we'll do a thing. We'll shift to the Meka Kirtana, are you ready? Kirtana?
Yes, ma'am. Good morning.
Yes, good morning. You are ready, right? Okay, Kirtana will be presenting a poster on immature teratoma, a case report. Kirtana, please start sharing your screen. Dipanjali will take you after this. In the meanwhile, you would just sort out your internet issues. Yes, Kirtana. It is very well visible and in a very good font size. You can start.
Yes, ma'am. Good morning, all of you. I am a junior resident from Rural Medical College, Luni. I'm here to present a case report on immature teratoma under the guidance of Dr. Bangal sir, our HOD. Ma'am, introducing germ cell tumors. They are the tumors derived from primordial germ cells of ovary. They can be malignant or benign. Teratoma is one of the most common type and it contains tissues representative of all three primary embryological layers. It is primarily classified into three types: the mature type, immature type, and a monoclonal type. Today's topic of discussion is immature teratoma, which contains anaplastic immature elements and is often synonymous with malignant teratoma. It displays a specific age of incidence occurring most frequently in the childhood and adolescence and almost never after menopause. They represent only 2% of ovarian teratomas, but account for 10 to 20% of ovarian cancers that are usually seen in the first 2 decades of life. I would like to present a case report which I've seen 3 months ago in our tertiary care hospital. There was a female 34-year-old married, para-3 living 3 with all 3 full-term vaginal deliveries presented in gynecology OPD with complaints of dull aching type of abdominal pain and abdominal distension since 3 months. On examination, Her abdomen was distended, and on palpation, a firm mass corresponding to approximately 24 weeks of gestation was noted, which was probably arising from the pelvis. On bimanual examination, right fornical fullness was noted with normal-sized anteverted uterus. On USG, findings were suggestive of a neoplastic mass lesion involving right ovary. CECT abdomen and pelvis was advised, which revealed a 17 into 18 into 11 centimeter sized solid heterogeneously enhancing mass lesion arising from the right adnexa, which was not seen separately from the right ovary, suggestive of right ovarian neoplastic mass. Her serum CA125 level was sent, which was raised with a value of 151.2 international units per ml. Patient was then admitted, routine investigations were performed, and fitness for surgery was obtained. Then patient underwent exploratory laparotomy. The presence of massive ascites and the presence of a firm 20 into 15 into 10 centimeter sized mass, which is mobile, originating from the right adnexa, but the left ovary being normal. Surgical staging of the tumor, according to FIGO, of stage 1C2 was done, and an intra-op decision for total abdominal hysterectomy with bilateral salpingo-oophorectomy was taken. Also, ascitic fluid was aspirated and sent for cytology. The histopathology report revealed immature teratoma, but the cytology of the ascitic fluid did not reveal presence of any malignant cells. Patient was discharged on post-op day 8 after complete suture removal with a healthy wound and was advised follow-up in oncology OPD. The patient presented in oncology OPD 2 months post-surgery with moderate ascites, and hence she was sent for review CECT abdomen, where omental cake formation along the greater omentum and multiple peritoneal and mesenteric deposits have been noted. Then patient has been started on her first cycle of chemotherapy with bleomycin, etoposide, and cisplatin. The discussion part is the immature ovarian teratomas differ from the mature cystic teratomas in that they demonstrate a clinically malignant behavior. They are much more and really distinguished by the presence of immature or embryonic tissues. Bilateral ovarian involvement is rare, but in a few cases of about 10%, they have a mature teratoma in the contralateral ovary. Tumor grading is based on the amount of immature neural tissue present in the mass. Tumor markers are usually not elevated unless the teratoma is mingled with another germ cell tumor types. Immunostains are usually not required for diagnosis, but they have the following immunoprofile. The neuroepithelium shows strong membranous staining for glial cell line derived neurotropic factor alpha 1, that is GFR alpha 1, and also often for octamer binding transcription factor 4, PAT6 and CD56. Treatment of immature teratoma consists of surgery and multi-drug chemotherapy, as most of the germ cell tumors, except dysgerminoma stage 1, irrespective of staging, are to be considered for chemotherapy post-surgery. The prognosis depends a great deal on the nature and amount of the immature component. For these apparent reasons, it is critical that regardless of its appearance or initial biopsy, all large teratomas need to be thoroughly and extensively sampled to identify any possible immature malignant component within them for proper and accurate diagnosis. Immature teratomas may sometimes be associated with mature tissue implants studding on the peritoneum, as seen in this case. Even though benign, these mature implants are resistant to chemotherapy and can enlarge during or after chemotherapy. Termed as the growing teratoma syndrome, these implants might require second look surgery and resection to exclude recurrent malignancy. I would like to conclude saying the morphological spectrum of immature teratoma of ovary is varied, complex, and offers diagnostic challenge to the gynecologist. Literature suggests mere presence of immature mesenchyme is not just sufficient. Accurate diagnosis is necessary for proper grading, management, and assessing prognosis of cases with immature teratoma. Thank you.
Thank you, dear. Now I invite judges for the questions round. Pushpa ma'am and Sumal ma'am.
Kirtana, stop sharing your screen. Yes.
Dr. Kirtana, it was a nice presentation.
Thank you.
How are you going to follow up this patient?
Ma'am, actually the patient has immediate post-surgery. Every case of germ cell tumor once diagnosed has to be referred. Actually, intra-op surgical staging according to FIGO has been done as 1C2. So any ovarian mass above grade 1A has to be followed up immediately in a oncology OPD. But this patient has not come for 2 months unless until she had complaints of severe abdominal distension. So now the patient has just come 10 days ago to our OPD, ma'am. So we have reviewed her to get her USG done where moderate ascites was found. And then we have referred her to oncology OPD where she was advised to do CECT. And then they have admitted her to start her on her first cycle of chemotherapy. Usually 4 cycles of chemotherapy are done, and review sonography has to be done to see the amount of deposits, the presence of any deposits.
Sonography will be sufficient to find out if there is recurrence or deposits.
CECT.
That's what I said. How you are going to follow up this patient? Immediate follow-up, that was okay. But now onwards?
Ma'am, she'll be taking her cycles of chemotherapy.
Are there any tumor markers for immature teratoma?
Ma'am, tumor, unless until it is commingled with some other tumor, as such, teratomas have no tumor markers.
Yes, so that is the problem.
Yes.
So that is why I asked you this. How to follow up these patients. Okay.
Yeah, Somala ma'am, any questions from your side? I think so. Somala madam.
Ma'am, can you unmute and start your video? I think ma'am is facing some technical problem. Pushpa ma'am, can we move ahead to the next presenter?
Yes.
Yeah.
Sure.
So our next presenter will be Dipanjali. She will be presenting paper on neutrophil to lymphocyte ratio.
Ma'am is here.
Okay. Ma'am, Sarita ma'am, you would like to ask question from the previous presenter?
Yeah, I think in immature, in your case, it was there was some problem in my net, so I could not hear it. But whether chemotherapy was given after the diagnosis, because most are malignant. Immature teratoma. Whether
Yes,
she is
ma'am.
there,
Ma'am, she said 4 cycles of chemotherapy given.
Ma'am, she was just admitted patient 10 days ago for her first cycle, and the first 3 days have been completed and patient has been discharged, and she's been called again 9th.
Okay.
For next dose.
So immediately she was started on chemotherapy after the diagnosis means, na? First primarily, after it was, no?
Ma'am, not immediately. Patient's compliance was actually poor. We actually told her to immediately, we actually referred her immediately, but she came after 2 months when she had distension.
Okay. Okay. So that is important, na? If she would have been given a chemotherapy, na? At that time after diagnosis, because most are malignant, na? Immature teratoma. Okay. 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 It was a nice case.
Okay. Ma'am, can we move on to next one then?
Yeah. Yeah.
Thank you, Mika. Now I call upon Dipanjali to present her paper on neutrophil to lymphocyte ratio and platelet to lymphocyte ratio in preeclampsia, a case control study. Dipanjali?
Yes, ma'am.
Dipanjali, yeah, your video is seen. Huh? Yeah. Make it in slideshow.
I'm Dipanjali Thumre. Under the guidance of Dr. Sulbha Joshi, I'm presenting the paper on neutrophil to lymphocyte ratio and platelet to lymphocyte ratio in antenatal women with preeclampsia, the case control study. Introduction: preeclampsia is a multisystem disorder during pregnancy in which there is a hypertension of hypertension 140/90 mmHg or more with or without proteinuria after 20th week of gestation in a previously normotensive woman. Incidence is 8 to 10% among pregnant women. The etiology of the preeclampsia is unclear, but some genetic predisposition, placental invasion, and immunologic responses are involved. Activation of inflammatory system with predominant involvement of the chemokines are seen in the preeclampsia. Evaluation of inflammatory status of preeclampsia. C-reactive proteins, platelet to lymphocyte ratio are the representative of the inflammatory markers in preeclampsia. Both the neutrophil to lymphocyte ratio and platelet to lymphocyte ratio are derived from the complete blood count and studied as a novel marker for the prognosis in patients in the preeclampsia. In these studies, the leukocytes are considered as a novel marker for the preeclampsia. Activated leukocytes, platelets, and vascular endothelium, in which the vascular injury causes the vascular injury. Neutrophil activation are the major component of exaggerated inflammatory response in the maternal vascular system. Another study is like the lipids secreted by the placenta causes the activation of the leukocytes, and they come in the maternal circulation and causes the vascular injury. Activity in platelet releases various soluble and adhesive molecules which triggers the interaction between platelets, leukocytes, and endothelial cells. There are some markers like oxidative stress such as the malondialdehyde, total antioxidant capacity, and the oxidative stress index, among others, show the high sensitivity in prediction of preeclampsia. But their routine measurement and the accessibility, especially at remote areas, is non-existent. Complete blood count test, which is readily available in almost all regions and district clinical laboratories and health facilities. Neutrophil to lymphocyte and the platelet to lymphocyte ratio will offer a huge for the management of preeclampsia. Normal range of neutrophil to lymphocyte ratio is 1 to 3 and the platelet to lymphocyte ratio is 90 to 10. The conclusion of this study on the neutrophil lymphocyte ratio and platelet to lymphocyte ratio in normal pregnant women and preeclampsia is different due to different research design, sample size, basic characteristics of the research subject. Some studies show that the neutrophil to lymphocyte ratio and platelet to lymphocyte ratio are higher in preeclampsia, whereas some shows no change. Some studies show change in NLR and PLR is also associated with severity of preeclampsia. The present study shows the neutrophil to lymphocyte ratio and platelet to lymphocyte ratio in preeclampsia compared with the normotensive antenatal women. The objective of this study is to determine the difference in neutrophil to lymphocyte ratio in preeclampsia as compared to normotensive antenatal women, and to determine the difference in the platelet to lymphocyte ratio in preeclampsia as compared to normotensive antenatal women. This is a case control study. The study population is from antenatal women attending obstetric and gynecology OPD and admitted in obstetric ward. The sample size is 140 and studied by convenience sampling method. Inclusion criteria is singleton pregnancy and book patient. Cases are the patients admitted in obstetric ward with the preeclampsia, and control is healthy normotensive pregnant woman attending OPD in obstetric ward and matching the age and gestational age. The exclusion criteria is gestational hypertension, chronic hypertension, gestational diabetes mellitus, thyroid disorder, tuberculosis, acquired infection during early stages of pregnancy, pre-existing vascular disease or pregnancy, history of alcohol or tobacco use, premature rupture of membrane, history of COVID-19 infection. Definition of the preeclampsia. According to the ACOG guidelines 2019, the systolic blood pressure of 140 mmHg or more, or diastolic blood pressure of 90 mmHg or more on a 2 or more occasion at least 4 hours apart, about 20 weeks gestation in women with previously normal blood pressure is a non-severe preeclampsia. And the systolic pressure of 160 mmHg or more, or diastolic pressure of 110 mmHg or more is a severe preeclampsia. Proteinuria, 300 milligram or more per 24-hour urine collection, protein to creatine ratio of 0.3 milligram per dl or more, or dipstick reading of 2+. In non-proteinuria, the following criteria are involved: thrombocytopenia, platelet count of less than 1 lakh, renal insufficiency, serum creatinine concentration greater than 1.1 milligram per dl, or serum creatinine concentration double in other renal diseases. Impaired liver function, elevated liver transaminase to twice the normal concentration, pulmonary edema, new onset headache, or the visual symptoms. The samples are collection of blood sample. About 3 ml of venous blood was collected in a clean and dry detailed bulb and from the Department of Obstetric Gynecology, and then sent to the Central Pathology Laboratory, and the sample is run by in the machine 5-part cell counter auto analyzer. Data collection to the case record sheet. Method of data collection: the National Ethics Committee approval was taken. Written and informed consent will be was taken. Detailed history, socio-economic factors noted. Physical and obstetric history noted. Clinical examination, general systemic examination was done. Normal routine antenatal investigation we are done. Based on ACOG criteria, patients of preeclampsia categorized severe and non-severe preeclampsia. Patients were managed as per hospital protocol. Data was entered in case record sheet and 2 groups were compared. Results. In case of age, socioeconomic status, parity, and gestational age, these groups are comparable, and there was no statistical significance it's seen. In case of neutrophil to lymphocyte ratio in cases and controls, there is statistical differences seen in 2 study groups. And platelet to lymphocyte ratio in cases and controls, that is a statistical difference seen in these study groups. In intra-group, in severe and non-severe preeclampsia, there was no statistical significance it's seen. In case of platelet to lymphocyte ratio also, in intra-group severe and non-severe preeclampsia, there is no statistical significance it's seen. There were some studies like Singh et al. And Giovanni et al., Priyanka G et al., showing there is a neutrophil lymphocyte ratios. Some studies like Nafia et al. Shows the decrease in neutrophil to lymphocyte ratio and platelet to lymphocyte ratio. Our present study shows the increase in neutrophil to lymphocyte ratio and platelet lymphocyte ratio in the preeclampsia cases. From this, the conclusion is the maternal neutrophil to lymphocyte ratio and platelet to lymphocyte ratio obtained from complete blood count and inexpensive routinely done test can be obtained as a biomarker in the diagnosis of the preeclampsia. However, further research is needed regarding predictive factors for preeclampsia with the purpose of starting preventive treatment in these cases, since the preeclampsia is pregnancy complication with serious implications in mothers and fetus. Thank you.
Thank you, Dipanjali. Nice presentation. Over to you, Pushpa ma'am and Savita ma'am.
Dr. Dipanjali, it was nice presentation. But how much value do you think you should give to this ratio that you have calculated? Then there are so many other factors which are quite helpful regarding right from prevention of preeclampsia and prediction of severity.
Yes, ma'am, but at remote areas where the facilities are not available and the complete blood count is routinely done tests that can be help in that areas.
You yourself said that more studies are required. So you will
Yes, ma'am. For
need to
further,
continue with this, then only you can say that it might be helpful.
it is one of the factor, ma'am, that can help in diagnosis of preeclampsia.
What are more
Or the
practical factors?
yes, ma'am.
What are better factors to, as compared to whatever you have done?
Ma'am,
Are there better factors already available?
yes, ma'am, but at remote areas, this can be a factor which can diagnose.
Which factors in which are not feasible in remote areas, according to you?
Ma'am, markers like serum uric acid levels and for the proteinuria. Then, ma'am, then inflammatory markers like LDH.
Eventually, urine protein can be done at remote places also with a dipstick, no?
Yes, ma'am.
And it can be done. I want to ask you one question, whether you excluded fever, like have you seen for fever, no? Fever can be one of the things which you should be excluding, no? In
Yes,
cases
ma'am.
as well as controls, no? Because
Yes,
it is any infection, evidence of infection anywhere can increase all these things, no? The neutrophils
Yes,
or
ma'am.
can have an effect. Okay. So you have not mentioned acute fever at the time whenever you are enrolling the patient in the study, because it can be increased with any fever of any kind. You only said COVID-19 infection, no?
Yes.
Okay. Okay, it was nice presentation.
Thank you, Dipanji. Thank you, judges. Actually, what I find in this study, as per se, preeclampsia is a systemic inflammatory response syndrome. So begin with at tertiary, what I could get out of your study, at the peripheral level, if we see that there is a rising trend in WBC, that at that moment, we can ask the patients to go to tertiary care center. And yes, there are easily, as madam said, blood pressure measurement, and these are the simple tools apart from the one which you have studied. So thank you all. Next, I call upon the next presenter. It will be Shraddha Thakre. She will be presenting a paper on genital TB in infertility. Shraddha?
Yes, ma'am. I'm there.
Yeah. Please switch on your video too.
Yes, ma'am.
Yeah, and please make it a slideshow mode. Your PowerPoint in slideshow mode, if you could. Yeah, very well. Thank you. Start, please.
Yes, ma'am. Good morning, all. Myself, Dr. Shraddha Thakre, resident of IGMC Nagpur. Today, I am presenting my paper on genital tuberculosis as cause of female infertility, which needs an evaluation. As we all know, in India, infertility has a very big issue. It has very big impact on the families and community. From all over the India, about 1/3 of Indian population are suffering from tuberculosis. And genital tuberculosis is responsible about 1/3, is the second most common extrapulmonary tuberculosis. All over the world, about 186 population are suffering from infertility. As we all know from all the gynecological admissions, genital tuberculosis is responsible for 1% of gynecological admissions. And the prevalence since 2011 was 19% of genital tuberculosis in India, and it increases from 19% to 30% in 2050. But current prevalence of genital tuberculosis is 3 to 16% in India. According to the pathological point of view, fallopian tubes are involved in about 100% of patients, and the tubers involved is usually bilateral. Followed by fallopian tubes, endometrium are involved in 50 to 80% of cases, and ovarian involvement as they are in about 20 to 30% of patients. But isolated ovaries are very less commonly involved. They are maybe present with tuberovarian mass or any adnexal lesions, and cervical involvement are only present in about 5 to 15% of patients. As considering all this point, and as infertility has a huge burden on our gynecological OPDs, and as in India, tuberculosis is a very common condition, we thought to study the prevalence of genital tuberculosis in infertility patient. My aims of study is to study the prevalence of genital tuberculosis and site of involvement of TB in genital TB positive patient. My study is the prospective observation type of study is held in October 2019 to September 2021. Total 250 cases were studied and analyzed. Detailed history was taken, type of fertility, past history, present history, radio diagnostic imaging and diagnostic hysterolaparoscopy was done. From about 250 patients, about 45 patients are tested positive for genital tuberculosis. From my study, which diagnosed with genital tuberculosis positive, most of the patients, that is 66.7%, has belonged in the age group between 21 to 30 years of age, with mean age of 27.9%. As we all know, genital tuberculosis is a disease of rural area, and most of the patients belongs to lower socioeconomic group. From my study, 93% of patients belong to lower socioeconomic group. From about 45 patients, about 40 patients have primary infertility, and most of the patients have infertility duration of 2 to 10 years. And these are 66.7% have this type of infertility of 2 to 10 years. In genital tuberculosis patient which are detected positive, from 100%, 27.8% has positive abdominal history, abdominal tuberculosis history in past, and 22.2% has pulmonary history in past. As we all know, tuberculosis detected in later stages, and in early stages, the symptoms is very less specific. From 100%, 44% are asymptomatic, and other major symptoms like low-grade fever and weight loss are present in only 30 to 40% of patients. According to menstrual disturbances, from 100%, 77.8% population has normal menstrual cycle, and oligomenorrhea and hypomenorrhea, which are more common and specific for genital tuberculosis, are present in only 15 to 20% of patients. These are some diagnostic aids. From my study, Montox is very sensitive for tubercular detection, but its specificity is very low as compared to other diagnostic modality. In our study, histopathological specimens, CBNAT, and culture are very specific for this for the detection of genital tuberculosis. From my study, about 48.8% of patients are diagnosed have tubercular lesion on histopathological examination. In HSG finding, most consistent findings were hydrosulfings and mid-tubal block, followed by 20% of patients who hydrosulfics with complete tubal block. We did chromoperturbation along with hysterolaparoscopic study. In about 27.8% of patients, bilateral delayed spill were there, and in 16.7% of patients, only unilateral delayed spill were seen. In laparoscopic study, most consistent finding with pelvic adhesion, which are seen in 34.8% of patients from 100%. This is most common finding is seen in all laparoscopic patients in genital TB detected positive. From uterine findings, about 50% of patients shows uterine indentation. And in tubal findings, hydrosulfics, B-date2s, and peritubal adhesions are the most consistent finding in tubal finding of laparoscopy. We compare my study with other studies. As we all know, genital tuberculosis is very is high detection rate in our India, and tuberculosis rate and its prevalence, which varies from India to India and country to country and yearly. In my study, the prevalence was 18.7%, but similar study was held in 2011 by Kulishetra. The prevalence rate for genital tuberculosis is very huge, that is 60.2%. But in Sharma's study in 2019, the prevalence of genital tuberculosis was only 5.5%. We compared other diagnostic modality from my present study with other study. In that, about 48.8% of patients has a histopathology specimen positive in my study. And in Shehzad's study, all 100 patients are detected positive with histopathological specimen. This type of result are not seen with Danish Zohra etiology. Only one patient shows patient shows histopathological specimen positive for TB. From this, we all know genital tuberculosis is a disease of lower socioeconomic group, and as genital tuberculosis present in very early stages and have asymptomatic presentation, and very less non-specific features are there as we discussed in infertility patients, as low-grade fever and vaginal disease are very non-specific features and in infertile patients, and as genital tuberculosis, and tuberculosis is most common etiological factor for in India in infertility evaluation. That's why we need to evaluate the all the patients are infertility for its further evaluation and its early treatment. From this, all the women with no definite cause of infertility should be evaluated for it, and management of genital tubule is aimed at recognizing the disease at early stages and in order to restore the fertility and its treatment. And medical treatment should be also supported with surgical and assisted reproductive technologies. These are some references. Thank you.
Thank you, Shraddha. Nice presentation.
Dr. Shraddha,
I would, yes.
I congratulate you for such an extensive study. It is a very good study.
Thank you.
But there are certain things I would like to point out. You said that 1/3 of Indian population, they suffer from tuberculosis.
Yes, ma'am.
Do you really think so? You have
Yes, I quoted the references, ma'am, from all over the India, tuberculosis, ma'am, all over tuberculosis, not just was genital tuberculosis, all over the
1/3 means 1 out of every 3 with people around you.
Yes, but ma'am, that is mostly undetected, as most of them has symptomatic presentation.
It is okay, but 1/3 is too much. 1/3 means you just imagine 1 out of 3 people who are around you,
yes,
they are having tuberculosis. Okay, and then you said something about this management and in take-home messages.
Yes, ma'am.
How are these patients managed once you have diagnosed that your patient of infertility is having tuberculosis?
Yes, ma'am. When we diagnose that our patient is having genital tuberculosis, we plan for AKT treatment. We register for it each and every patient in RNTCP.
Okay,
and we use
complete the treatment with anti-tuberculous drugs.
Yes, ma'am. Anti-tuberculosis, and we followed after 2 to 3 months for repeated hysteroscopy, and after that we plan the treatment of patient.
How does this lesion heal when you give anti-tuberculous drugs? Suppose she is having tuberculous self-injectis. You have already done the hysterosalpinography and then notice or whatever you have mentioned.
Yes, ma'am. Most of the patient after AKT
lesions heal.
Yes, ma'am. Most of the patient, ma'am, of tuberculous self-injectis after AKT, most of them have fibrosis, tubal fibrosis and tubal block after AKT, ma'am.
Yes. So to treat the infertility, what is the best modality?
Ma'am, assisted reproductive technology and embryo transfer is the best modality of treatment in after treatment of genital tuberculosis.
Will you attempt anastomosis in case you find tubal block?
Ma'am, at present not, ma'am.
So assisted reproductive technology means exactly what will you like to offer to these patients?
Ma'am, we will plan. We should advise, ma'am, in vitro fertilization and embryo transfer in this patient, ma'am.
In vitro fertilization. What complication do you expect in these patients?
Ma'am, infertility is the most common complication, most common presentation of it, and in some patients, uterine perforation was there, extensive intrauterine adhesions were there, ma'am.
No, after
and ovarian mass were there.
And then she attempts pregnancy.
Yes, ma'am.
Once you treat this patient and she attempts or she goes for some treatment for infertility.
Yes.
In that case, I am asking.
If she conceives, no, after treatment, which pregnancy, any complication, whether it will be intrauterine always or anything?
Ma'am, after pregnancy, the most common complication is ectopic pregnancy, ma'am. The most common complication is ectopic pregnancy is the patient, as most of them have tubal block and tubal adhesions where the ectopic presentation is most common in this patient.
Okay. And one thing I wanted to ask, any patient had a amenorrhea, secondary amenorrhea in your presenting as amenorrhea?
Ma'am, yes, ma'am. Ma'am, I only quoted oligomenorrhea and hypomenorrhea, ma'am. But yes, ma'am, 20 to 30% of patients had, ma'am, secondary amenorrhea.
In your study, they had a secondary.
Yes, ma'am. In menstrual symptoms, I quoted oligomenorrhea, hypomenorrhea, normal menstrual cycles, polymenorrhea, and secondary amenorrhea.
You have mentioned secondary amenorrhea.
Sorry, ma'am, I did not mention in this slide, ma'am.
So that is very important, na? So as to plan, na, if there is a secondary amenorrhea with end organ damage, Asherman syndrome, then there will be problem, na, to do all the things ART also.
Exactly. So why there is amenorrhea?
Transfer and you will not be able to do, na, in them then.
Why there is amenorrhea?
Ma'am, due to intrauterine adhesions, ma'am.
Amenorrhea.
So,
is there any other cause? Can there be ovarian tuberculosis?
Yes, ma'am.
How do the patients present initially? If she is having tuberculous endometritis, another patient is having tuberculous selphangitis, third patient is having endometrial, that is ovarian.
Most of the patients, ma'am, are present with oligohypomenorrhea, ma'am, in this type of endometrial tuberculosis.
In active infection, suppose there is tuberculous endometritis, how will she present?
Ma'am, in active infection, first there is a heavy, there is a history of polymenorrhea, and in later stages the patient present
heavy menstrual bleeding.
Yes, ma'am, heavy menstrual bleeding, and in chronic cases, ma'am, after treatment, they present as oligohypomenorrhea.
So that this amenorrhea is not because of Asherman syndrome.
Yes, ma'am.
The endometrium is destroyed.
Yes, ma'am. In Asherman syndrome, patients may mostly present with secondary amenorrhea.
What is the difference between this Asherman syndrome that you are talking about and Asherman syndrome that is usually present after vigorous curettage or iatrogenic Asherman syndrome? What exactly is Asherman syndrome?
It's due to intrauterine adhesions, the patient presents with secondary amenorrhea.
Yes. So in tuberculosis, why should there be intrauterine adhesions?
Ma'am, due to healing of active lesions, they result in intrauterine adhesions, which may later present as secondary amenorrhea due to destruction of endometrium.
So initial part, the patient may present with heavy menstrual bleeding. No? So in adolescent AUB, usually consider this also diagnosis in our developing country.
Yes,
okay. It was nice, huh? Nice study.
Thank you, ma'am.
Thank you, ma'am. Thank you so much. As Somarva ma'am rightly said that some patients may lead to secondary amenorrhea. In such cases, it is because of destruction of the basilis layer, and such patients can have even issues with ART and embryo transfer because her basilis layer will not be in a state to grow, and that will lead to like thin endometrium, hyperechoic endometrium, and poor endometrial receptivity. Thank you so much, ma'am, for throwing light on this part of the topic. Now, before delaying, I welcome the next presenter, Rashmi Sakharwade. She'll be presenting a poster on normal obstetrics outcome in Neurofibromatosis 1. Rashmi. Rashmi. Are you ready, Rashmi? I think Rashmi is taking time, ma'am. Shall we move on to the next presenter, Monica?
Yes, because time.
Monica, is Monica ready? Yes, Monica, you're there?
Yes, ma'am.
Are you ready?
Yes, ma'am.
Can you share your screen?
Yes, ma'am.
Okay, Rashmi has shared the screen. I'm sorry, Monica. I think Rashmi has shared. We'll come to you next after Rashmi is done.
Yes, ma'am.
We are back to Rashmi, ma'am. We are back to Rashmi Sakharwade. Yes, Rashmi, you can start presenting.
Good afternoon, everyone. Respected chairperson and my dear colleagues. I'm going to present my poster on normal obstetric outcome in neurofibromatosis. Neurofibromatosis is a genetic disorder which is autosomal in dominance associated with a multitude of clinical manifestation with the rare presentation in pregnancy, incidences with 1 in 4,000 pregnancies. Presenting one such a case, 22-year, second gravida with abortion 1, married for 2 years, with gestational age of 38 weeks, came with the complaint of labor pain. On OBS history suggestive of abortion of 2 months, which was spontaneous, for which suction evacuation was done. In family, her mother is also a case of a neurofibromatosis 1. She is a book case at a private hospital, and she is a known case of neurofibromatosis once since childhood. History suggestive of exacerbation of the cutaneous lesion with increased size and pigmentation since second trimester. Her antenatal period was normal. On examination, general examination, her BP was normal. Height is 152 centimeter, pulse 78. And on local examination, patient has a multiple dark colored nodular to non-tender lesion of varying size from 1 to 2.5 centimeter, as you can see in the picture, which is present all over the body. Her systemic examination was normal. Per abdominally, uterus is full term, breech, and she is in a latent phase of labor. Her section was done under spinal anesthesia. A full-term normal female with 2.5 kg with Apgar score of 810, 910 delivered. Postpartum period was uneventful. Now few words about neurofibromatosis 1. It's a single gene disorder with the mutation of the neurofibrin 1 gene on chromosome number 70, which is due to the activity of the loss of neurofibromin protein. It is inheritance through parents, or it may have a spontaneous mutation. Peripheral neurofibromatosis is also known as von Reichen's disease. It is associated with manifestation from mild to severe form. Mild manifestation is mild cutaneous lesion. To the severe manifestations are like plexiform neurofibromas, optic gliomas, some of the bony abnormalities like scoliosis, pseudoarthritis, and very rarely it can transform into the malignancies. Effect of disease on pregnancy: it may lead to spontaneous abortion, preterm delivery, preeclampsia, HELLP syndrome, and intrauterine growth restriction. Now, the effect of pregnancy on disease is there is an increased number and the size of cutaneous neurofibromatosis throughout pregnancy, which decrease after the size of the neurofibromas decrease post pregnancy, and that is because the estrogen receptors are found on the neurofibromatous lesion. You can see these are the postpartum images of a patient, which shows that there is significant decrease in the size of neurofibromas. The chances for cesarean section in the neurofibromatous increases. That's because of fetal distress, malpresentation, cephalopelvic disproportion, because of kyphoscoliosis. The chances for cesarean section is found to be 28 to 30%. Prenatal diagnosis here is possible. We can do chorionic villus sampling, amniocentesis, and but the severity of manifestation is not predictable in neurofibromatosis men. We can do the selection of embryo and embryo transfer. Counseling has a very important role in neurofibromatosis. As from the above case, we can conclude that the neurofibromatosis is a rare genetic disorder with known pregnancy complications. There is exacerbations of lesion and possibility of the prenatal diagnosis. The outcomes are unpredictable. They may be vary from mild to significant severity, and possibility of even normal obstetrics outcome also possible. And of course, the counseling awareness is very important. Thank you, ma'am.
Thank you. Now I invite the judges for the questions. Pushpa ma'am, Sonal ma'am.
Quite a rare and interesting case, and very well presented. Now this mother might ask, what will be the outcome in the child?
Ma'am, the outcome in child, baby may have preterm delivery.
No, not the outcome of pregnancy.
Hello.
Hello, am I audible?
Yes, ma'am. Yes, ma'am.
Now the outcome of pregnancy about the child in future.
Rashmi, you can speak. Your screen got stopped sharing, but you are seen. So you can speak and answer madam's question.
Ma'am, can you please repeat the question?
The mother will ask what is the outcome in the baby.
Ma'am, baby may require NICU admission as the child may be preterm, may having the fetal distress. And in future, the baby can be again having the neurofibromatosis, ma'am.
What are the chances? You will have to ask, answer all these questions asked by the family members.
Ma'am, it may vary from mild to severity, ma'am. At the age of 10 years, till 10 years, we can't say the baby may have neurofibromatosis. After 10 years, there is a increased chances, and the baby can have the signs of neurofibromatosis.
Over to you, Savita madam.
Yeah, Somal ma'am. Ma'am, could you please unmute yourself? Somal ma'am? Yeah. Okay, till we see ma'am again, maybe internet issues. Yeah, ma'am. Ma'am, your voice is not very clear.
Yes, ma'am.
Can you hear me now? What you in your page?
Ma'am, your voice is not clear, ma'am.
If you could text your question, then we can ask on your behalf, ma'am. Maybe. In the meanwhile, if madam is texting, I would like to ask from Pushpa ma'am, from our side, such cases happen to come in emergency and we do have problem. So one thing clicked in my mind, what if we have to take her for cesarean section? So while giving an incision, if we come across these lesions, so are these lesions in any way, will they cause any problem in healing, primary in healing or secondary healing?
No, I don't think so. They are so extensive that there are high possibilities that they will come in the way.
Okay.
And they are not highly vascular. Neither they are infective.
Not infective. Even if a 2 or 2 it comes, we can tackle it. Yeah. Thank you. Savita ma'am, Somal ma'am,
Yeah.
Ma'am, if you could type your question in the chat box. Actually, your voice is not very clear.
Okay. Yeah. Go ahead with next.
Okay, we will go ahead. Okay, ma'am. Thank you. Pushpa, we'll go ahead with the next question, next presenter then. So for next, we have Monica Sangani. She'll be presenting poster on placenta previa with bladder invasion. Monica?
Yes, ma'am.
Yeah, please start.
Good afternoon, everyone. I'm Dr. Monica Sangani, junior resident in IGGMC Mayo Hospital. I'm presenting a poster on placenta percreta with bladder invasion under the guidance of Dr. Bhakti Deshpande, ma'am. So placenta accreta spectrum are most commonly associated with previous LSCS, likely due to abnormal placentation, secondary to loss of deciduum and caesarean scar. Other risk factors are advanced maternal age, multiparity, previous uterine surgeries like myomectomy, uterine curettage, etc. In normal pregnancy, placenta anchors to residualist endometrium. Abnormal invasion of placental trophoblast results in placenta accreta spectrum, which consists of accreta, increta, and percreta. Incidence in 1960s were 1 in 30,000. Now it is 1 in 53 in the 2000 studies. So my case summary comprises of a 30-year-old gravida 4 para-2 live-2 with previous to LSCS. She was a known case of hypothyroidism, was at 36 weeks of gestation. Patient came to the labor room referred from the private hospital with fetal ultrasound suggestive of complete placenta previa with breech presentation. She had no complaints at the time, so she was further investigated. An MRI of the pelvis was done, which was suggestive of the disruption of the hypointense line at the myometrial interface by placenta involving posterior superior surface of the urinary bladder with multiple vascular flow voids within placenta and at placental myometrial interface, as you can see in the picture. The placenta was also low-lying, completely covering the internal os. Decision to operate the patient electively was taken with anesthesia and physician fitness done. With well-written informed consent, the patient was taken for cesarean section. She underwent a classical cesarean section by the obstetrician team. On inspection, the placenta was involving the posterior superior wall of the urinary bladder, as you can also see in the picture. The baby was delivered out by breech. A viable 2.5 kg female neonate was delivered. The placental tissue was left in situ, and the decision for obstetric hysterectomy was done. Intra-op surgeon's call was done for the fundal involvement of the urinary bladder. The fundus of the urinary bladder was inspected by the surgeons, and the placental tissue was left in situ. And methylene blue dye test was done, and there was no bladder rupture. The post-op catheter was draining clear urine. Patient was admitted in the surgical ICU for 2 days. She received 3 units blood transfusion, and she had multiple spikes of fever, which was managed conservatively. Her HPE report was traced and was suggestive of exaggerated placental site reaction in the sense of myometrial fiber hypertrophy with infiltration of multinucleated trophoblastic cells into the myometrium without an intervening layer of the decidua. The Foley's catheter was removed on day 8, and the drain, which was kept in the POD, was removed on day 10. Post-op USG on day 10 of the urinary bladder was done, suggestive of 26 into 20 mm of focal thickness. The patient was advised MRI and cystoscopy. Management of the patient. The main complication we encounter is hemorrhage in placenta previa with percreta. Our case was managed as I discussed above, but the other modalities are surgical devascularization of the uterus by attempting separation by separating it from the urinary bladder. It decreases the uterine hemorrhage, If the parity is not complete, the placental tissue can be left in situ with adjuvant treatment with methotrexate can be given. In conclusion, I'd like to conclude that after review of our case and current published data, multidisciplinary approach is of utmost importance for the life of the patient and the baby. Thank you.
Thank you, Monica. Thank you so much. Nice case and a nice presentation. Over to you, Pushpa ma'am and Somila ma'am. Ma'am is there.
Nice presentation, Monica, of a nice case. Now you said something about leaving the placenta in situ.
Yes, ma'am.
Giving methotrexate.
Yes, ma'am.
You said that the patient was multi, it is easy to decide about obstetric hysterectomy. But suppose she is gravida 2, para 1, but no living issue.
Yes, ma'am. So in such cases where the parity is not complete, ma'am, I left the placenta and placental tissue in situ. And
tissue means the whole of the placenta is accreta or it is partially adherent?
The partially adherent placenta, ma'am.
Which is more dangerous, completely adherent placenta or placenta adherent partially at places?
Partially adherent placenta at places.
Why? Why?
Sorry, ma'am, I don't know that.
Which cases are easier to manage or give you less worry? Completely adherent placenta or partially adherent placenta? That is patchy adherence.
Patchy adherent placenta.
I asked you the reason why.
Sorry, ma'am, I don't know that.
Okay. Nowadays, we are not giving methotrexate because whatever tissue you are leaving behind, it is not a living tissue. Methotrexate helps only in living tissue. Any other disadvantage of giving methotrexate?
Ma'am, it is nephrotoxic and hepatotoxic. It causes leukopenia and thrombocytopenia in the patients. So the side effect profile of methotrexate.
And this newly delivered patient, she has anything else to do? Methotrexate might affect that function. Will she be able to breastfeed her baby if she is given methotrexate?
No, ma'am.
That will be an added problem. Congratulations, however, for managing such a case nicely.
Thank you.
Thank you, ma'am. Sumarla, ma'am. Sarita, ma'am. Ma'am, I guess Savita ma'am is facing some technical problems. Shall we start with the next presenter, ma'am? Pushpa, ma'am?
Please go ahead. Please go ahead. Actually, we are.
Savita ma'am is facing a little technical problem, I guess. Ma'am, we are not able to hear you.
Okay. Hello.
She is online now.
Savita ma'am is here.
Yeah. So in her case, my hello.
Yes, ma'am. Your voice is breaking a little. Ma'am, please ask. Yes, yes. Now we can see you, ma'am.
Yeah. Controversy regarding, I think madam has already, Sundara madam has covered it. Controversy. Methotrexate. Can you tell Monica?
Yes, ma'am.
Controversy? Okay. I want to add one thing. Can you hear me?
Yes, ma'am, we can hear you very clearly. Very clear.
Yeah, because it leads to immunosuppression. Na? Patients are more prone for infection, not because the placenta is degrading. It is because of the immunosuppression by the methotrexate. Patient may have a infection, septicemia. Also, that is the one thing that should be kept in mind. Yeah.
So we don't give it prophylactically.
Yeah. We don't
We
give.
can give only when we see beta HCG rising trend or we have a suspicion.
Yeah. And breastfeeding also. Breastfeeding
is also contraindicated.
It will be contraindicated. Methotrexate. Yeah.
Yes, ma'am. Thank you so much, ma'am. Thank you, Monica. Nice case so that everybody could learn from your case. Thank you, Pushpa ma'am and Savita ma'am, for giving your valuable inputs. Now I request the next presenter, Tushar Rahane, to present his poster on acute abdomen, a surgeon's dilemma. Tushar is presenting from Shraddha's device, I guess. Yes, Tushar. We can see you.
Yes, ma'am.
Yeah.
I'm sharing my screen, ma'am.
Yeah, start sharing your screen, no problem. Yes, the screen is visible.
Just a minute.
Yeah, zoom it a little.
Yes.
Can you zoom it?
No, ma'am.
You'll have to zoom it because we are not able to read anything.
I can't zoom it.
If you escape, press your escape button.
Yes, ma'am.
Yeah, now zoom from here first.
Bottom, right bottom.
See, right side, there is
Bottom.
zoom option.
Yeah.
Yeah. Now you can just slide your screen. Okay, it is still going on the same. Okay, start. Ma'am, are you comfortable with this kind of vision? Pushpa ma'am, Savita ma'am? Okay. Okay, start presenting, Tushar.
Difficult.
It is difficult, Tushar. I think you escape it and don't go into the slideshow mode. And here only you zoom it
This
up.
is a bit better.
This is better. You
Thank you.
present it this way.
Yes, it's okay now.
Yeah. Thank you.
Can I start?
Yes, start, Tushar.
Good afternoon, everyone. Myself, Dr. Tushar Rahane, IGMC Mayo Hospital. I am presenting a poster of an acute abdomen surgeon's dilemma under guidance of Dr. Kshama Kedar ma'am. Pyometra is uncommon condition in gynecology with incidence of 1% occurring mainly in elderly postmenopausal women. Pyometra is the occlusion of cervical canal due to cervical stenosis by malignancy due to senile changes. Spontaneous perforation of pyometra and subsequent peritonitis is very rare and result when natural drainage of uterine cavity was compromised. Here I am presenting a case. A 70-year multiparous female came admitted in surgical ward with complaints of severely diffuse abdominal pain with high-grade fever, nausea, and multiple episodes of vomiting since 3 days. Recent history was weight loss and the loss of appetite. On examination, patient was cachexia, ill look, temperature was 102 degree Fahrenheit, respiratory rate 24 per minute, pulse 126 per minute, blood pressure was 160, SpO2 98% on room air. On general, on per abdominal examination, there is tenderness, guarding, and rigidity. Laboratory result was HB 8.6, TLC count 28,000, sodium potassium was normal, serum create 1.6, and blood urea 84, ECG within normal limit. USG suggestive of moderate interbowel collection with multiple echoes within it, with edematous bowel loop present, with tap suggestive of pleural discharge. CCT suggestive of moderate peritoneal collection with multiple air pockets and smooth peritoneal enhancement suggestive of pyoperitoneum and peritonitis. Chest X-ray suggestive of air under diaphragm. Diagnosis was gastrointestinal tract infection. The patient on emergency patient exploring under the general surgery they perform a exploratory lab. 900 cc pus abdominal pus is drained from abdominal cavity with uterine drained on anterior fundic wall of uterus of size 5 × 6 centimeter. Endometrial thin out with the fragile with endocervical growth present with no gastrointestinal tract perforation. The case was handed over toward the gynecologist. The uterus and cervix removed and sent for histopathological examination. After total abdominal hysterectomy and bilateral salpingo-oophorectomy, patient received one point blood transfusion intraoperatively. Histopathological examination suggestive of poorly differentiated squamous cell carcinoma. Here is the image of this uterus, perforated uterus with cervix, the thinning of the uterine line. The patient post-operatively patient was stable for 1 day. Then patient went to the shop on post-op day 2. Patient not retrieved and succumb on day 2. Here is a diagram of histopathological report, squamous cell carcinoma, poorly differentiated squamous cell carcinoma. The discussion was pyometra is the accumulation of purulent material in uterine cavity. The benign and or malignant condition cause accumulation of secretions and gradual enlargement of uterus, leading to thin uterine wall, which may slough with spontaneous uterine rupture and peritonitis. Once rupture, symptoms become severe and acute abdomen often develops. One of the differential diagnoses of rupture uterus due to pyometra in old women should be kept. Malignancy should be ruled out in elderly patient. Conclusion: The diagnosis of spontaneous perforation of pyometra is the rarely made preoperatively, and possibility of perforated pyometra should be therefore be considered when patient suffers from acute abdominal pain. Elderly women should be examined for any cervical or vaginal lesions. Hysterectomy and bilateral salpingo-oophorectomy is the best choice of procedure in this patient. The references are given. Thank you very much, ma'am. Thank you very much.
Dr. Tushar, congratulations
Yes,
for handling this, or in fact, diagnosing this case.
Yes, ma'am.
Tell me, was this patient never complaining of any postmenopausal bleeding or anything?
Ma'am, the patient was referred from rural hospital to the casualty, and due to the pain in abdomen and collection in abdomen, the patient initially admitted and evaluated under the surgery. They
it is all right. That is all right, but after knowing the diagnosis, that it turned out to be perforation of pyometra, pyometra. Did you retrospectively ask the patient whether she had any postmenopausal bleeding history?
Ma'am, the patient came with the one of the hello, ma'am.
Yes, you are audible. Go ahead.
Patient came with the her relative, which was not too much educated, and it was too much difficult to take a retrospective history from her, ma'am.
No, actually, I think there was delay in many things. That is, maybe the patient reported very late.
Yes, ma'am.
But pyometra, they have got different ways of presentation.
Yes, ma'am.
And we do come across patients coming directly with some this sonography report mentioning that it is ovarian tumor and it turns out to be pyometra. Maybe this patient was neglected by herself and her relatives, so that maybe few weeks or few days back or few months back also, she might have had some complaints like postmenopausal bleeding, and it was totally ignored.
Yes.
What was the cause of death?
Ma'am, patient went to the shock. Patient was admitted post-operatively in surgical ICU. Went to the shock, ma'am.
Malignancy was of uterus, endometrium, or cervix?
Cervix, ma'am. Cervix, ma'am.
So it is. We usually do not enumerate causes of death of cervix as pyometra or septicemia. This is, of course, a very rare cause, but it should be kept in mind.
Septicemic shock, I think, in her case, na, as she came late.
Yes, ma'am.
And whether Rahul, any intervention was done outside any time per vaginally?
No, ma'am. Actually, the only USG abdomen was done there, and CCT also for the abdomen.
Why do you think Dr. Samalwar madam asked this question to you? Any intervention outside?
Sorry,
yes. Do you think such uterus they will rupture spontaneously simply because the patient is aged? What is the possibility?
The uterus, pyometra, if we try to drain vaginally, it is very soft and there can be perforation, because spontaneous, maybe the growth has gone beyond that. It means uterine involvement. Hence, I wanted, Rahul. Whenever we are draining the pyometra, we are very careful and we do not do most of the time curettings in the same sitting. No?
Yes.
Tushar, do you know this? It is dictum not to put a curette and curette out anything, because there is fear of perforation of the uterus. Whenever we come across patients of pyometra, we post only for drainage of pyometra and maybe cervical biopsy, but never put in the curette.
Yeah.
Or even a sound.
So it was very nice, interesting case. Yeah.
Yes. Thank you, ma'am.
Okay, Tushar, just for my information sake, I just wanted to know whether any perspiculum examination was done, because there is seen some cervical growth, and in your case history, I'm not seeing any perspiculum examination.
Ma'am, in such case, we got the case add on the table, At the time, the surgeons explore only in view of the interbowel collection, peritonitis, or gastrointestinal tract. We not
Okay,
got
the
a
case
time
went
to.
to surgery people first.
Yes,
It did
ma'am.
not
On
come to
table
the
we got the
denied
case.
casualty.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
I think Amrita, it must be endocervical growth, na? No?
Yeah.
Because if she not have no symptoms, na? Maybe endocervical growth. No?
We really don't know the previous history. We don't know whether outside any speculum examination or anything like that. Anyways, thank you, Tushar. That was really an interesting case. We'll move on
Thank you,
to
ma'am.
our next presenter, Rajat. Rajat Agarwal. He'll be presenting poster on a case of post-preterm uterine inversion followed by cervical prolapse. Over to you, Rajat.
Yeah, yes, ma'am. Yes, ma'am.
Yeah, Rajat, could you just click on your video and start sharing your screen?
Yes, ma'am. Just a second, ma'am.
Yeah.
Ma'am, is my presentation visible to everyone?
No, Rajat, you need to share it actually.
Just a second.
Yeah. Okay. Yeah, Rajat, it is seen, but I think so a little bit of zooming in if you can do it. A little. Judges, are we okay with it?
Is that?
Pushpa ma'am.
Yes, it is visible.
Okay. Please, Rajat, start.
Good afternoon, everyone, respected judges, seniors, and my dear colleagues. Today, I'm here to present a very rare case of post-preterm uterine inversion, which was followed by a cervical prolapse under the guidance of Dr. Shama Kedar ma'am. Acute uterine inversion is a very rare and potentially fatal obstetrical emergency. Inversion of the uterus is referred as to the turning of the uterus inside out, where the fundus prolapses inside the uterine cavity above or below the cervical os. The incidence is very variable. It is around 1 in 8,500 deliveries in India, and about 1 in 20,000 in US and 1 in 27,000 in UK. While repositioning of the uterus is not immediate, excessive bleeding can cause hemodynamic instability and shock. Excessive umbilical contraction with a fundal attachment of the placenta and fundal pressure in a setting of relaxed uterus are the two most common proposed etiologies for uterine inversion. My case was a 35-year-old female, PNC, para 3 live 2, early neonatal death 1 with all vaginal delivery, came to labor room with a chief complaint of bleeding per vaginum with pain in abdomen and something coming out of vagina since 1 hour. Patient gives history of 29 weeks of amenorrhea with history of vaginal delivery at home 3 hours back, with history of umbilical cord traction by self, as placenta did not expelled out immediately after the delivery. On general examination, her general condition was not satisfactory. Her blood pressure was 80 by 50 millimeters of mercury. Her pulse was 146 beats per minute. Her saturation was normal on room air. She was conscious but very much irritable. On per abdominal examination, uterine fundus was not palpable, and there was tenderness on deep palpation over suprapubic region. On local examination, a large globular tender reddish mass with irregular surface was found protruding through the introitus. A diagnosis of preterm delivery followed by acute complete uterine inversion with hemorrhagic shock in severe anemia was made. We successfully performed manual reposition of the uterus followed by internal manual compression for 15 minutes, following which uterotonics were given along with crystalloids, and 1 pint PRC was given as her hemoglobin was 6.5 gram% on admission. A total of 2 pint PRC was given in a span of 3 days. On day 3 of admission, patient started complaining of something coming out of vagina again after she went for defecation, and on examination, it revealed out to be a 3rd-degree cervical descent with edematous cervix, and it was reposited back immediately along with one pack in the introitus for 1 day. Uterine inversion is such a rare condition that there have been only one case reported after a preterm delivery. After a purpurine inversion following a full-term delivery and abortion is seen very commonly, but there has been only one case which has been reported in the literature after a post-preterm delivery, which has been reported in the Brazil. Uterine inversion is a rare since the introduction of active management of third stage of labor. Depending on the time of lapse from the delivery, it can be classified into acute, which is within 24 hours, subacute between 24 hours and 4 weeks, and chronic, which is after 1 month. And on the extent of inversion, it can be classified into first degree, which is fundus at the level above the level of internal os. Second degree, fundus passes through the internal os but lies within the introitus. Third degree, which is fundus extend outside the introitus. And our case was a case of fourth degree uterine inversion, which was acute in onset. A peripheral invasion at the main cause of the two main proposed etiology is a fundal plus attachment of the placenta and mismanaged third stage of labor. Also adding to the contributory factor, multiparities and short umbilical cord is one of the factors. There are various management strategies included in the textbook, which includes surgical and non-surgical methods. Non-surgical methods include two strategies, that is Johnson's and O'Sullivan hydrostatic method, and surgical method includes Huntington, Spinelli, Holton's, and Kastner operation. Majority of the acute cases revert back to normal position with the non-surgical maneuver due to high elasticity of the uterus and its surrounding structure, as it was seen in our case, which we were able to manage with Johnson's maneuver in repositioning back the uterus. Conclusion: uterine inversion is such an obstetric complication that, due to its gravity, requires rapid diagnosis and immediate clinical action. It's low. It is such low and rare in incidence that it leads to sparse experience among the health professional and medical officers in managing this obstetrical emergency. Thank you.
Thank you, Rajat. Nicely presented case. Over to you, Pushpa ma'am and Savita ma'am.
Very good collections of rare cases are being presented today.
Yes, ma'am.
Rajat, you said that there was contraction given by self, that is by patient herself.
Yes.
She delivered the baby herself.
No, ma'am. Actually, she went into preterm labor, and she belongs to a low socioeconomic class. And in her community, people usually don't come to hospital and perform institutional delivery. So they were of the opinion that the baby is already been delivered, so we can deliver this by themselves only, and that is the reason why she did self umbilical contraction.
Self or some dye or some.
No, self. She was actually she was there alone in her home with one relative with herself, but which both of them did not have any experience. So that is the reason why she was, and she lives in a rural area where there was no facility of transport or facility of any healthcare facility was available to her.
Okay. Looking at this history now, can you immediately tell how to prevent such accidents?
Ma'am, to prevent such accidents, ma'am, one should definitely the primary health centers of India should be strengthened to such a level.
You are delivering the patient. You are delivering the patient.
Okay. Okay. If I'm the one who is delivering the patient has come to us with already delivered baby, so I would like to first.
Can you switch on your video so that everybody can feel connected to you?
Okay, ma'am.
Some problem, I think, in his video.
No, he was visible initially when he was presenting.
We are not able to see you. It's okay. If you're not able to do it, please proceed with the answer.
Ma'am, if such a patient comes to us with a case of uterine inversion, first I would like to.
No, you are. I asked you a question. When you are delivering a patient.
Okay, ma'am.
How will you prevent this accident?
Ma'am, by performing active management of surge of labor, that is, controlled cord traction, and we should not.
What is this controlled cord traction? Can you describe? How do you
with the non-dominant?
You deliver the placenta.
Okay.
When you deliver the patient, how do you deliver the placenta?
Ma'am, ideally we should not. No,
I am just asking you a direct question. How do you deliver the placenta?
Ma'am, by keeping a non-dominant hand on the suprapubic region, and giving traction to the umbilical cord in a controlled way so that the uterine inversion doesn't occur.
No, just putting your hand over the suprapubic region will suffice?
No, ma'am, not just putting.
What is the purpose of keeping this hand over the suprapubic region?
Anything you
Ma'am, the
want to
purpose
do?
of I would like to start with uterotonics after the delivery of the baby, ma'am. And ideally, we should wait for the placenta to deliver it by itself, so that
Then it is not active management of labor. If you are waiting the placenta to deliver on its own, that is not active management. You are
yes,
actively
ma'am. That is
managing the patient. You did mention control cord traction, but you didn't describe it. Yeah.
Okay, ma'am. With the non-dominant, I would my non-dominant hand I would keep it on the suprapubic region to prevent uterine inversion while giving traction to the cord with the dominant hand.
Keeping the hand will suffice.
Only
And,
keeping hand. And what you will do with your hand, left hand?
Ma'am, giving uterine massage also, but that is not included in the active management.
No,
not before, na? Before delivery of placenta. Massage is not before delivery, na? You will interfere with separation then.
You have to give counter traction. You have to push the uterus towards the umbilicus.
Yes, ma'am.
I am always of the opinion that is before learning cesarean section, hysterectomy, students, they should learn to deliver the patient normally, vaginally.
Yes, ma'am. Yes, ma'am. Actually, I was not able to put it in words, but yes, ma'am.
It is okay, but you have understood how to deliver placenta?
Yes, ma'am. Definitely.
Okay. So simply putting the hand doesn't suffice.
Yes, ma'am. We have to give counter traction on the against the traction of the umbilical cord. We have to give traction, counter traction with the non-dominant hand on the suprapubic region.
Correct.
To prevent uterine inversion. Yes, ma'am.
Okay.
In your case, Rajat, when patient came, the placenta has already delivered. Means she
yes, ma'am.
Pulled it and it was delivered. Okay.
Yes, ma'am.
She must have had a tonic BPH because BPs, she was in hypotension when she came to you. Shock
yes, ma'am.
already.
She was in hemorrhagic shock, ma'am.
Nice presentation. Rare case, na? Rare.
Yes, ma'am.
Thank you, ma'am.
This is the first one in India, ma'am.
Yeah. Thank you, ma'am. Thank you, Rajat. As ma'am said, the counter traction with your non-dominant hand, actually that is the dominant part of your control cord traction, which will prevent this kind of situation in any delivery which you will conduct, or you will be the obstetrician and wherever you will conduct. So that opposite direction counter traction with your non-dominant hand is really an important step to prevent this situation. Thank you so much for sharing such a good case. Now we move on to the last presenter of the session, Neha Tandulwarkar. She'll be presenting a poster on pelvic actinomycosis mimicking uterine fibroid. She'll be using Monica's device. Neha, are you there? Can you hear me? Yes, Monica?
Yes, ma'am.
You start sharing your screen. Sorry, Monica, it's Neha.
Yes. Is it visible, ma'am?
It is visible. Make it slideshow.
And I won't be able to zoom it, ma'am.
Okay, zoom it in this presenting mode only. Zoom it. Zoom it a little more.
Is it okay, ma'am?
Okay. Yeah, you can start presenting.
Good afternoon, everyone. Myself, Dr. Neha Tandolkar, and I am presenting a poster on the topic of pelvic actinomycosis, which was mimicking uterine fibroid under the guidance of Dr. Kshama Kedar ma'am. Actinomycosis is a chronic bacterial infection caused by actinomyces, which is a gram-positive anaerobic bacteria. Its symptomatology imitates some malignant pelvic tumors, tuberculosis, or nocardiosis causing abscesses and fistulas. These are opportunistic infections and they require normal mucous barriers to be altered. Pelvic actinomycosis can affect any age group and it is secondary to perforation or fistulation. Pelvic actinomycosis unrelated to intrauterine copper devices. They are almost associated with previous surgical procedures and the symptoms, clinical signs, radiological findings are usually non-specific, mimicking and uterine fibroid. The most common etiological agent is Actinomycosis israeli. In my case, a 40 years old multiparous perimenopausal woman presented at the gynecology department of the IGGMC hospital with complaining of pain in abdomen since last 1 month, which was on and off. She denied any history of vaginal discharge, any history of IUCD insertion, or any history of surgical procedure except for a tubal ligation done 10 years back. She was not on any chronic immunosuppressive drugs. On investigations, her complete hemogram was within normal limit except for a increased lymphocyte count, which was 3,000. And USG pelvis suggested a thick wall multiloculated cystic mass of 4.7 by 4 by 4.1 centimeter with echogenic foci inside in the right adnexa with query subserosal posterior uterine wall fibroid with left ovarian hemorrhagic cyst. When the patient was taken for surgery, and we found that the pelvic organs were densely adherent to the omentum and bowel, and a diagnosis of query frozen pelvis, query tubercles, and metastasis was made. We also found out a right-sided simple ovarian cyst of 5 by 4 centimeter and a right-sided tuber ovarian mass of 5 by 4 centimeter densely adherent to the right corner of the uterus. Sigmoid colon was adherent anterior to bowel and thickened terminal ileum was observed. Peritoneal fluid was collected and was sent for CBNAT. Multiple hard nodules were present all over the omentum and multiple nodules were present throughout the bowel. Right-sided cyst aspiration was done and sent for histopathology, and excision of the right-sided tuber ovarian mass was also done after adhesiolisis and sent for histopathology along with the palpable nodule of omentum and mesenteric lymph node biopsy. Postoperatively, her hemogram was within normal limit with decrease in the lymphocyte count. A respiratory medicine consultation was taken for the initiation of the anti-tuberculous treatment, and patient was started on AKT. However, Mycobacterium tuberculosis was not detected in the CBNAT of peritoneal fluid. On histopathological examination of the cut section of the tuber ovarian mass, showed fibrocollagenous tissue comprising of dense aggregates of the round eosinophilic structure with eosinophilic amorphous material with club-shaped configuration surrounding it, consistent with the findings of the morphology of the sulfur granules surrounded by the lymphohistiocytic infiltrate with foreign body giant cell reaction, which is nothing but the Splendor-Hopley phenomenon. The cut section of the omentum also showed sulfur granules with the giant cell reaction suggestive of the pelvic actinomycosis. Hence, a diagnosis of pelvic actinomycosis involving the right ovary, the right fallopian tubes, and omentum was made. Patient was started on oral group of penicillin, that is tablet painted 400 mg BD, to be taken for 1 year. Currently, the patient is on oral antibiotics and is asymptomatic. Actinomycosis is a rare granulomatous suppurative inflammation, suppurative disease, with pelvis being the rarest area of presentation. About 85 to 90% of the cases of pelvic actinomycosis have association with intrauterine copper devices presenting as pelvic tumor syndrome or pelvic inflammatory disease. The symptoms of pelvic actinomycosis can imitate symptoms of gynecological malignant tumors, uterine myoma, or adenomyosis when presenting as a genital mass without fever. This infection can disseminate to the uterine tubes and cause salpingitis and subsequent destruction of the ovarian parenchyma. So here I conclude that the pelvic actinomycosis is very confusing to diagnose, and it should be considered in the differential diagnosis of the pelvic chronic inflammatory disease, and it should be kept in mind whenever we are dealing with cases such presenting as tuber-ovarian abscesses, as they may make pelvic or intra-abdominal malignancy. These are my references, ma'am. Thank you.
Judges, any questions?
It was very nice case, Neha. Also heard for the first time actinomyosis leading to all this. Whether your patient had heavy
the same thing.
bleeding?
We came across quite rare cases today.
Yeah.
Spontaneous perforating Pyometra and the myosis also.
Whether she had heavy menstrual bleeding?
No, ma'am.
No.
But
No
only
discharge.
was pain in abdomen since last 1 month.
Okay. So short duration of complaints with.
Pushpa, any questions from your side?
No, actually, even I have heard this case for the first time. So,
So Neha, you have made every one of us speechless, right? Thank you, Neha. And thank you, Pushpa ma'am. Thank you, Savita ma'am, for chairing and judging this session. It was really lovely and nice having you here. Special thanks to Pushpa ma'am for extending her time, which we had allotted, and giving us her valuable inputs. Thank you, Savita ma'am, too. Now heading on with our next thing, thanking ceremony. First of all, I would like to thank NOGS and Department of POCSO for organizing such feast and the first day of paper poster presentation. I thank all the judges, Dr. Suchi Jain ma'am, Dr. Savita Somalwar ma'am, Dr. Shama Kedar ma'am, Kausalkar ma'am, Pushpa ma'am. I thank all the participants for presenting such rare collection of cases. And I also thank my co-MOC and rest of the audience for logging in. Looking forward to for the rest days of our academic feast. Thank you. Good day.
Thanks, Amrita and Rita. It was very nicely conducted.
Thank you, ma'am. We'll be having another 3 days of sessions of great academic feast. As we started today with the paper and poster presentation, we all know that paper and poster are the best way of depicting your science. So this is the way how we can bring out our rare case scenarios. Such case scenarios are happening all over the world. But unless and until it is put down in pen and it is put down on words on paper, we won't be able to, get enlightened with such cases and cannot learn from such cases. So near future, we are welcoming such scenarios more and more, such platforms more and more, so that we can present and share such cases. And next 3 days, it's going to be a double booster game because we are going to have good case vivas and table vivas and discussions, which is going to benefit every student, every postgraduate for the upcoming exams, and not just the postgraduates, but also the faculty members, so that we are also in continuous learning process. So everybody is requested to do login next 3 days, and it will be from 12 o'clock. The link will be shared each day in the morning, and the link will be continued same, and you'll have to continue logging to the same link, but the timings will be from 12 o'clock in the noon. So we'll meet you everyone next 3 days. Thank you so much, ma'am.
okay, thank you and congratulations team in NKP Survey, VGI department and NOGS.
Thank you, ma'am. Thank you so much.